Pourquoi j'ai pas de son? L'enceinte est éteinte. Ça marche pas. De quoi?
Non, non. De toute façon, moi, il est avec le PC, je suis maudit. Dès que je touche le PC, je peux vous donner.
C'est parce que c'est trop bas. A, et, C, et. Tester. Tester. Oui, oui. C'est correct. Terminer le test. Non, ça. Ok. Je sais pas pourquoi il me la retourne l'image à chaque fois. Ça, c'est vraiment un mystère. Bon, nous, c'est bon, ça c'est testé, ça marche. Ensuite, il reste ça à voir. Test son, test son. Pour Benjamin, est-ce qu'on nous entend? Voilà, c'est un test son. Test son. Oui, bonjour Benjamin, Alexis à l'appareil. Bonjour. Je fais un test. Je recule le son. C'est bon. Je faisais juste un test son, savoir si c'est passé. Voilà, je fais un test son. Est-ce que tu m'entends? Voilà, test son. Test son. Et moi, ça me module chez moi. C'est bon, parfait, super. Bon, ben, bonne journée. Allez, à plus tard.
C'est toi qui ouvre, c'est bon? Non? Ah bah, c'est pas le charme. Ah non, c'est moi qui cherche. Ouais, c'est le cher de la maison. On va le mettre dans le temps. J'ai 30 minutes.
30 minutes.
Ça marche. Hein.
Tu vérifies hein, que tu ne nous arnaques pas.
Non, non, non. Et après, en fait, ça c'est Nicolas qui m'a laissé le topo.
Bah, après, c'est sûr, après, ça va être encore des tables rondes, mais je pense.
Ouais, okay. C'est loin.
So, good morning. So thank you for, I hope you enjoyed your dinner yesterday. So this is the second day of the EMSCO meeting, and this morning we start with Olivier Hermine. So I think we need to start on time because you know Olivier. So Olivier talk about mastocytosis. So thank you, Olivier, for coming, and the floor is yours.
Okay, so good morning, everybody, and I'm sorry to wake you up with mastocytosis, which is a very interesting disease. So today I have the task to provide you some information on HAN and mastocytosis. So here, where's the first slide? It's me, that's the slide. Okay, so I will show you some work that we have done in the reference center of mastocytosis in Paris and with Julien Rossignol. So as you know, the classification of mastocytosis is quite complex, and usually we split the disease in two parts, what we call the pure cutaneous mastocytosis and the systemic mastocytosis. And among the systemic mastocytosis, we have what we call the no advanced mastocytosis, representing 90% of the patient, and the one which we call advanced mastocytosis, the one who will kill the patient eventually. And in this group of patients, we split also between indolent mastocytosis, in which you have no what we call C findings, and smoldering mastocytosis, in which you have a lot of mast cells in the bone marrow, eventually a splenomegaly, but no cytopenia, no liver insufficiency, and the life expectancy of this patient is normal. And then we have the systemic mastocytosis with associated hematological neoplasm, what we will talk today, the aggressive mastocytosis and the mast cell leukemia. In all cases, you have what we call the C findings. The patient may exhibit some cytopenia and liver insufficiency, and they may die of the disease. So among the systemic mastocytosis with associated hematological neoplasm, we can split again into the one associated with lymphoid neoplasms, which is rare. I will not talk on that today, but I will focus on myeloid neoplasms. And we can split them between MDS, MPN, and most of the cases are more MPN, MDS-like, and we don't know exactly, and acute myelogenous leukemia. And the most neoplasm which is associated to mastocytosis is CMML. So even to make more complication, when we look at the mastocytosis itself, we can split also depending on the subtype of mastocytosis, and we call the BMM. BMM, it's pure mastocyte in the bone marrow and no mast cells elsewhere, and usually they have the typical features of round mast cells. We call the indolent systemic mastocytosis with few aggregates in the bone marrow and with no insufficiency. As I said, the smoldering mastocytosis, in which we have some kind of myelodysplastic features and massive involvement of the bone marrow and splenomegaly, and the aggressive mastocytosis and mast cell leukemia. And to make the diagnosis of mast cell leukemia, you need to perform bone marrow aspiration, and you have more than 20% of mast cells at the aspiration. And the bone marrow biopsy cannot make the diagnosis of mast cell leukemia. Sometimes you have like 100% infiltration in the bone marrow biopsy, but none mast cells in the bone marrow aspiration. In this case, it may be aggressive mastocytosis, but not mast cell leukemia. So I think I summarize the complication of the classification of mast cells. So when we look at the epidemiology of this disease in the past, there is few papers with a small number of patients, and you see, depending on the center, probably there is some bias, but you have between 10 to 30% of the patients who are some associated neoplasms. And how you make the diagnosis of this patient. So first, you do, as usual, the clinical findings, and it's very important to see if the patient has some weight loss, which may classify the patient as aggressive mastocytosis, and the splenomegaly, and the portal hypertension and ascites, which is a complication of mast cell infiltration in the liver. And you have to check if there is some cytopenia, or if you have proliferation of monocytes or eosinophils, which are quite frequent. And you look at the tryptase level, albumin, and phosphatase alkaline, which are associated to the poor prognosis when they are elevated. And then you do the bone marrow biopsy and the bone marrow aspiration if you want to classify the mastocytosis. You take the level of tryptase, because if you have the low tryptase, probably the mast cell burden is low, and the tryptase is high, so mast cell burden is high. And now we do check in the peripheral blood by digital PCR the X16V mutations, or you can do it by NGS, and it's very important to assess the VAF in this patient. Then you look at the C findings, which are the cytopenia and the ascites and weight loss. It's very important. Now it is required to do NGS to look for additional mutations, and will have a very strong prognosis impact. And the cytogenetics, which is usually normal in mast cell because they cannot proliferate ex vivo. So, but you may assess the HN with the cytogenetic. And then you can make a diagnosis of the mastocytosis, as I said, indolent, aggressive, and so on. And you can subtyping with HN, and you can make a prognosis with these few tests, which is not very difficult to do. So, something which is very interesting, when we looked at the mutation in mastocytosis, we found some additional mutation. And very interestingly, when you look at the indolent mastocytosis, usually you have, in all cases, the KIT mutation, but no additional mutation, or very few. But when we look with aggressive mastocytosis, you have additional mutation, and particularly one with SRSF2, SLX1, and RUNX1, which are associated with a poor prognosis, and TET2, which is frequent, but mainly in indolent mastocytosis or aggressive mastocytosis with no poor prognosis features. And so here it is what we think in terms of physiopathology of HAN. So in some stem cells, you may have some associated mutations. And in these stem cells, you may have some kind of secondary mutation, which is c-KIT. And then you have the aggressive mastocytosis in this case. And depending at the level where this mutation occurred, you may have some associated neoplasms, and some of them, they may bear the c-KIT mutation, and some they do not, depending where the c-KIT mutation occurs. So in some cases, you have early KIT mutation and then secondary mutation, but in some cases, you have first the clonal hematopoiesis mutation, I should say, and then you have the KIT mutation. So if we summarize, in indolent mastocytosis, usually you have only the KIT mutation in mast cells, and the other lineages are not involved with the KIT mutation. Then when you look at the SM-HAN, you have the KIT mutation, and also you may have some other mutations, but when they are indolent, I should say, there is very few mutations, but sometimes you may see TET2 mutation associated to the CMML, or mutations which induce some kind of myeloproliferative disorders, like, for example, JAK2, and which is the case here. And you may have additional karyotype deletion if you have an MDS, but KIT A16 is only in the mast cells, and you have usually a systemic mastocytosis with no aggressive features. And when you have this kind of mutation like SRSF2, SLX1, or RUNX1 plus KIT, you can find this mutation both in the hematological neoplasm, but also in the mast cells. And in this case, you have an aggressive mastocytosis in most of the cases. And then when you have a complex karyotype, you have usually a poor prognosis associated hematological neoplasm. So depending on the VAF of the kit and other mutations, you may predict the outcome of the patients. Something which is very interesting when you look at the patient with advanced systemic mastocytosis, sometimes it's difficult to classify the patient because if you see cytopenias, they may be due to the HN, but not to the involvement by the mast cells in the bone marrow. And you missed, if you are not very careful, when you make the diagnosis of HN, you may miss systemic mastocytosis in 20% of the cases if you don't look at the serum tryptase as a KIT S16 mutation, because if you don't look at these both parameters, you may miss the systemic mastocytosis component, and you have also to stain the bone marrow with tryptase and with c-KIT, and eventually with CD2 and CD25, because mast cells in the bone marrow, when they are abnormal, they do express these two T-cell markers. Now, then, if you have an indolent systemic mastocytosis, you may miss the HN. And in this case, you have to do to check for c-KIT A16. And in this case, usually the burden is higher than you do expect when you look at the mast cell infiltration, meaning that the KIT mutation is another component of the proliferation. And you may see some monocytes and eosinophils, which are usually associated with systemic mastocytosis with HN. So here it is, when we look at the presence and the expression of this mutation, SRSF2, SLX1, and RUX1, there are very strong prognosis values. As you can see here, when you have no mutation, you see the prognosis of this patient is very good, even if they have an aggressive mastocytosis with or without an HN. But now, if you have one of these mutations, you see the prognosis drop dramatically, and two is even worse. So you have to check. And now, in the new classification, we take in account this mutation to make and to have a prognosis index for this patient. And this one is what we call the MARS index, in which you take in account the age of the patient, the level of hemoglobin, the level of platelets, the presence of this mutation, and then you have some classification and value, and then depending on the number you are low, intermediate, or high. And you can see here, you can split very nicely the patient depending on these parameters. So here you have a good prognosis, and here you have a very poor prognosis. And when we try to assess the value of the presence of HN in the prognosis, you see here, regardless the disease associated to the systemic mastocytosis, you cannot split them. But if you use the MARS score, you can see very nicely, you can split also the patient depending on the MARS score, even if they have some hematological neoplasm. So I think it's very critical to use this score because you can see what you are doing when you do some clinical trial. And interestingly, there is some mutation like JAK2, for example. If you have the JAK2 mutation, the KIT mutation, but no SAR mutation, you see the prognosis is very, very good. And if you have no JAK2 and no SAR mutation, and SAR mutation is very poor. And here, when you're JAK positive plus SAR, you see the prognosis is not so bad. So I think the JAK2 mutation is associated to the good prognosis when you have a mastocytosis, even if you have the SAR mutation. So, as I said before, how you can help you to classify and to make the diagnosis of SM and HN. When you have a patient with an HN, you should check for, as I said before, the clinical examination to see if the patient has a past history of anaphylaxis, which may think that he may have some mast cell activation. And you look also at monocytosis and eosinophilia, because this one is associated usually with also mast cells in a significant amount of cases. And you look at some parameters like albumin and phosphatase alkaline, which are elevated in mastocytosis, but not usually in HN alone. And very importantly, you look at the tryptase level and the quantification of the A16 mutation in the peripheral blood. So now you have some picture in which, for example, you have a low tryptase, and you have an ICM component with a low KIT burden in the peripheral blood. Usually, it is an HN with an indolent systemic mastocytosis. Now, in contrast, if you have a high level of tryptase and high level of KIT burden, it's maybe in most of the cases an aggressive mastocytosis associated with the HN. So you can help you to make the difference between the two, because it might be very important when you look at the treatment of this patient. So here in the past, we could make some kind of prognosis of the patient depending on the classification. Obviously, when you have a cutaneous mastocytosis, you see virtually all patients are not dead. And there's a similar expectancy of life than the regular population. In contrast, the patient with mast cell leukemia are doing poorly, and the patient with aggressive mastocytosis also. But here, you have the group of patients with associated neoplasms, which is not very good, in the past. So with Julien, we take the European network and we make an analysis of patients with HN at a large scale in Europe, including also some center in the US, for example, in Stanford. And so out of 4,000 patients, we can retrieve 400 patients. So it means in the biggest registry in the world of mastocytosis, 10% of the patient has some kind of HN. And what is interesting is we see more in male HN, like usual, and probably there's some kind of anti-oncogene in the X chromosome. And when we make the definitions, I will not come back, but I told you that we have to make a very fine classification of different mastocytosis that we did here. And we did the same thing also for the neoplasms and so on. So you see, and we have some classification of MDS and PN, which is a patient with some kind of a proliferation, but also MDS features like high leukocytosis with neutrophil or monocyte and so on. So when we look at the patient characteristic, in most of the cases, you see you have more often some advanced mastocytosis associated with the neoplasms. Most of the cases is aggressive mastocytosis in 60% of the cases, and few are mast cell leukemia, which has the principal feature of this patient. And when we look at the repartition of the neoplasms, it's more often MDS and PN in 40% of the cases, and 15% with true pure MDS, and then you have the rest of the proliferation. The skin is less involved when you have an hematological component, so it's not surprising to see no skin involvement in patients with HN and mastocytosis, which is important. And when you look at the symptoms of the patient, they may experience some flush and pruritus, which is, you have to think about mastocytosis when you have a patient with these symptoms. And also they have some GI tract symptoms significantly more when you have an HN that without HN. The tryptase level, obviously, is higher when you have an HN component, when you look at the patient with no HN component, which is very important. And importantly, you have more eosinophils and more monocytes in patients with an HN component. The KIT mutation is virtually present in all cases, and most of the cases is the A16 mutation, so you cannot differentiate HN and no HN based on the KIT mutation. And you see you have a small variant, but they are quite similar in the two groups of patients. But here, which is very important, you have more additional mutations. So what's important, you have the KIT JAK2 mutation here. You found it more in non-advanced than in advanced mastocytosis, as I told you before. And something which is important, we have more SIR mutation, 65%, and which is very important also, you lose the CD2. And when you have a loss of the CD2, it's of high prognosis value. It's usually associated to neoplasm and also with a poor prognosis. So when we look at the prognosis of the patient with all type of systemic mastocytosis, when you have an HN, you see the prognosis is poor when you compare to the patient with no HN component. Here it is a survival in months. And now if you split in non-advanced and versus advanced mastocytosis, you do see here, and also you can split the patient with no HN versus HN and in the same. So in both groups, to have an HN is associated to the poorer prognosis when you have a mastocytosis. And when we look here, if you look at the patient with an HN, and if you look if he has a mastocytosis component, you see when you have a non-advanced mastocytosis is better than advanced mastocytosis, which is expected actually, but it is confirmed in this large scale. Now, if you look at the type of neoplasms, I think for the first time we can differentiate, because in the past, all studies showed that regardless the the HN component, the prognosis was poor. But you can see here with a large number of patients, the patient with MDS, MPN, do better than the one with MDS or other kind of HN associated to mastocytosis, which is important. And here, when you look at the patient with non-advanced mastocytosis and what we call MPN, you see the prognosis is very good. And here it's mostly patients with essential thrombocytopenia or PV or sometimes myelofibrosis. But in advanced mastocytosis, you can see there is no difference regardless the type of neoplasm, meaning that probably the prognosis here is due to the mast cell component more than the HN. So when we look at the multivariate analysis with respect to the overall survival, you can see here that when you have an MDS or you have an advanced mastocytosis, and when you're old also, is associated to the poor prognosis independently. So if you look at the treatment, nobody, because most of the drugs which have been registered now in mastocytosis has been done based on phase 2 study. There is no comparative study to assess the real effect of, for example, ITK. And so we look at the presence of A16 mutation, and in this group of patients, we assess the value of treatment with ITK, including midostaurin and avapritinib, and the patients with wild-type KIT, some receive imatinib. So you can see here, for the first time, we show in the real life that when you receive an ITK, you have a much more better prognosis than if you don't receive ITK. So I think this data is very important because it shows you in the real life that to receive ITK, blocking A16 mutation, is associated to the better prognosis, even in patients with HN components. So it's very important to notify that. And in multivariate analysis, also, you see that to receive ITK is associated significantly, independently, to the better prognosis for this patient. So to conclude this first part, you can see that SM with HN occur more often in patients with old age, with more advanced mastocytosis, with less skin involvement, and with more infiltration, with a less expression of the CD2, and usually with a higher tryptase level. The prognosis is better when you have an NPN, particularly the one associated with the JAK2 mutation. So, and the TKI improves the overall survival. And in the future, it will be very important to see if you have an hematological component with an HN to assess if the mast cell component play a role in the prognosis of this patient. So you can see here a nice study from the Mayo Clinic showing that patients with CMML, when they have a SM component, you see the prognosis is less good than the patient without a mast cell component. So now let's look at the treatment of this patient. So you see for the last 20 years, we made a lot of improvement to treat this patient because before we had only steroids and alpha interferon, and then the KIT inhibitors came on the market. And now you see we have in the future a lot of new treatment, mainly the one you use in MDS actually. So first, the cladribine, which is a nucleotide inhibitor, you see it has been very a good treatment for indolent mastocytosis, to clear the skin lesions. And sometimes it's very important for patients to have a clean skin. And you can see here it's quite very successful. And when we look at the symptoms, most of the symptoms of patients with mastocytosis are improved when you treat these patients with cladribine, and quite rapidly actually. But when you look at the components and the cytopenia and the eosinophilia and monocytosis, nothing is working in this patient. You can see here the decrease of the infiltration of mast cells in the bone marrow. And when you look at the overall survival of this patient, you improve the patient with indolent mastocytosis, but they don't die, so it's difficult to improve it. But you see there is no clear improvement of the overall survival of this patient when they receive cladribine. And same thing for the PFS here. And when you look at the patient with the hematological component, you see there is no clear improvement. It's not like the patient without this HN component. So I think cladribine is not the first choice for patients with an HN, except maybe the few one with a myeloproliferative disorder. So I will come now to the KIT inhibitors. So in the market, you know, there is, or in development, some KIT inhibitors, and two are particularly interesting here. The first one was the midostaurin, but you see it's some kind of a dirty KIT inhibitors because it virtually blocks like more than 200 kinases, but it has a good effect on the X16 mutation in comparison to other kinase inhibitor. And the last one, which probably is the best because it's more potent on the KIT A16 mutation and more selective also on the KIT A16 mutation and doesn't block other kinases. So the first study with midostaurin include patients with aggressive mastocytosis, and some of these patients have also HAN, and you see they have also in a significant number of cases the SAR mutation. This drug, in contrast to what we are thinking before, is quite well tolerated except for the GI tract secondary effects, which are not very well tolerated in some patients. When you look at the response, the overall response rate in all group of patients is about 60%, but very few patients experience some a complete response. You see like less than 10%. And when we look at the response across the different subtypes of mastocytosis, and you see it's quite similar if you have an aggressive mastocytosis and HN component or a mast cell leukemia with 60% overall response and less than 10% complete response. And midostaurin is a real modifier because you see a decrease of the mast cell burden significantly, and also you see a decrease of the tryptase level and the spleen volume in this patient, and also you see the decrease of the KIT A16 burden in the peripheral blood. And its overall survival, you see we do have a very good result in mast cell leukemia and less probant, I should say, in HAN and mast cell leukemia. So in the real life, also coming from Germany, a retrospective study have shown that the use of midostaurin versus historical control improve also significantly the overall survival in these patients, and which is also, as I said before, better when you use cladribine. So here we can say we should not use cladribine now that we have KIT inhibitors. But unfortunately, when you look at the patient with a mutation with SAR, you see the prognosis is not good, even when you treat this patient with midostaurin. So midostaurin is not able to overcome the poor prognosis of the SAR mutation. So now let's look at the avapritinib, which is the last drug on the market for A16. So in the Pathfinder phase 2 study, I will go fast here. Patients were included with aggressive mastocytosis, and you see 60% of the patient has this poor prognosis factor. So it's a poor group of patients with a high tryptase level. And you see the overall response was quite impressive when you compare to what we did see before with midostaurin, because it is 80% overall response in this group of patients with 20% complete response, which we never see that with any other drugs. And also, it's a very disease modifier treatment because you see a nice reduction of mast cell infiltration in a significant number of cases and lower the level of tryptase and the spleen volume, and also the KIT mutation in the peripheral blood, which translates in a very good prognosis, because you can see here the overall survival is quite good for the patient with aggressive mastocytosis. And also you see here, which is quite interesting, we didn't see any differences between mast cell leukemia and the one with the HAN component in this study, and overall survival is a similar findings. And same thing when you compare to real life, and the patient will receive avapritinib versus best supportive care or best care, you see it's even better when you look with the treatment with patient with avapritinib. So it seems that to have a better potency on KIT may improve significantly the outcome of this patient. So I will go fast with this one. So now one of the questions, and which was very interesting in this study, it's that patients with CMML have sometimes a mast cell component. When you look at the data registry, it seems that when you have a CMML, the risk to have mastocytosis is 25 higher than the general population. So it's, I think, very important to look when you have a CMML at mastocytosis component and when you have the mastocytosis to look at the CMML component because it's quite frequent. And as I said before, to have a mast cell component in CMML is associated to the poor prognosis. But interestingly, when you look at this data, although the patients are dying earlier when they have a mastocytosis component, the risk of transformation to leukemia is lower in the group of patients with mastocytosis. So probably they died of the mast cell disease or other disease, maybe cardiovascular events in this group of patients. So when you look at patients with mastocytosis treated with avapritinib, very interestingly, some of them have monocytosis and they have MPN, MDS, and you see here that in most of the cases, you see a nice drop of the number of monocytes, and you have sometimes the total disappearance of the monocyte in the peripheral blood of this patient. You can see here nicely. And same thing when you have a hypereosinophilia, you see also a drop of the eosinophils, meaning that blocking KIT may have an impact on the HAN and here on the monocyte number. And I think there is no drug that provides such effect on monocyte in CMML in this patient. And so now what we try to discuss, and this was an abstract with international abstract, including Eric Solari group, in which they have assessed the mutation of KIT in patients with CMML. And very interestingly, they found in 20% of the cases the presence of the mutation of KIT S16 in the peripheral blood of this patient, although most of these patients has no diagnosis of CMML. And when you look at the prognosis of this patient, interestingly, the secondary MML occur in 40% in the wild type versus 29% of the KIT mutation, which is protecting against the risk of transformation of leukemia. But in contrast, the response to hypomilitary agent was lower in patients with the mast cell S16 mutation with no complete response. So I think it's very interesting because it protects against the transformation toward leukemia, but prevents the response to classical treatment of CMML. So what is the hypothesis to see such a response with avapritinib? Obviously, as I said before, monocyte components do not express the KIT protein. They may have the mutation, but they do not express the KIT mutation. So it's not driven directly, the monocyte component, by the KIT expression on this monocyte. So with avapritinib, obviously, we block the mastocyte component, but why we do block the monocyte component is still something that we do not know, and we plan to do it and to study it with the Eric Solari group, and probably it might be due to the release by mast cells in the bone marrow of some cytokines, and which may stimulate the monocyte component, and particularly the CD30 ligand, which is expressed by mast cell, and CD30 might be expressed by the monocyte. So I think it's something that we should look for it, and we have a nice discussion to try to see if we can treat patients with CMML with a KIT component, regardless the VAF of this patient, with avapritinib to see if we can decrease the number of monocytes in the group of patients. So something it's currently in discussion. I think it will be very interesting to discuss that with the MDS group, because maybe in this case we will have some improvement of the monocytosis, because we have seen that in patients with mastocytosis, but also we may improve also the cytopenia. Something that we have done to try to find new target, because as I told you, only 30% of the patients reach complete response. We look at the BCL2 expression in patients with mastocytosis, and interestingly, only the patients with aggressive mastocytosis do express highly BCL2 at the immunohistochemistry level. And when we treat this patient here, for example, with midostaurin, interestingly, you see a decrease of the mast cell component, but you see the selection of some kind of cells that express highly BCL2, which may explain why they don't die, because they express BCL2 and they survive on BCL2. And we make the hypothesis that the expression of BCL2 is not dependent on the KIT mutation, but more on the hedgehog pathway, and published a paper on blood last year showing that the hedgehog pathway is involved in the physiopathology of mast cells with abnormal constitutive expression. And in vitro, when we take some cell line, we see here that you have, with the treatment with midostaurin, we block the expression of BCLXL and MCL1 in the cell line, but we have no effect on the BCL2 expression, meaning that by blocking KIT, the cells will survive only because they have a high level of expression of BCL2, but not BCLXL or MCL1. So if you do block BCL2, you may expect to see apoptosis of the cell, which is the case actually. You can see here when you do the combination, you see an apoptosis of the cells because they rely only on BCL2 for their survival when you treat the patient with a KIT inhibition. And here it is some clinical example of patients with midostaurin with no response, and the addition of venetoclax leads and results in a drop of tryptase level, showing in vivo that the combination of KIT inhibition plus BCL2 inhibition leads to complete response in this patient. And here it's the patient with AML and mastocytosis, and we did the triplet combination with azacitidine and venetoclax for the AML component, but we add also midostaurin because there is a mast cell component. You can see here a nice decrease in the patient with CR for the two diseases. Unfortunately, a relapse of the AML component, which is expected, unfortunately, in this group of patients. But here we can show that this combination may work and may be useful for this patient. So now we try to set up a protocol in which we will treat patients with midostaurin or avapritinib, and in case of no complete response, we will add venetoclax in the hope to be able to reach complete response in this patient. And I will finish to allo stem cell transplantation because it's something that we have to consider mostly for the HAN component in this patient. And this one is the whole study we have done retrospectively, showing that some patients may benefit from stem cell transplantation, and particularly when they receive myeloablative conditioning regimen. And you see the patient with the HAN also are the one who respond the best to a bone marrow transplantation. And you see this patient receive allo stem cell transplantation, relapsed after allo stem cell transplantation in the mast cell component. He received DLI and went in complete response, showing that mast cells, they may respond to the GVL effect. So how to treat the patient? Now, currently, it's first, it's better to include patients in clinical trial, like usual, but it's something that we say every time. And we have to use the TKI, midostaurin, because it's the one we have to use in first line. And in case of intolerance or no response, you can shift for avapritinib, which is better to improve and to deeper the complete response. And then if you have aggressive mastocytosis, you may do exactly the same thing. And for SM-HN, it's more complicated because you have to treat either first the HN component or the mast cell component. But in all cases, depending on the prognosis factor and particularly the MARS score, you may consider allo stem cell transplantation, and you have a window in which you can do it, because when you block the mast cell component, the patient may improve his general status, and then it might be ready to receive a stem cell transplantation. So here, I will not go very fast, very long on this slide, but it's when you have a patient with a two component, you have to check what you have to treat in first place. And if you have like more mediator symptoms and high tryptase level and high KIT burden, you may treat first the stem cell, the mast cell component. In other cases, you may treat first the HN. You have a strong cytopenia with a low tryptase, low KIT burden, it's better to treat first the HN. In other hand, if you have high tryptase, high KIT burden, and cytopenia, treat first the mast cell component. So we go fast here. And this one is an interesting case, you know, when we have a patient with an HN component, you treat the patient with a KIT inhibition, you see the burden of KIT goes down, and you see the selection of the clone with a poor prognosis factor like SRSF2, SLX1, and ROX1. And here you see the HN component moving up. So when you follow this patient, you have to look at the VAF and the clonal evolution of the disease, because when you do see that, you have to consider bone marrow transplantation, because you know that this patient will evolve rapidly to high-risk MDS or acute myelogenous leukemia. Here you see the selection of a clone with P53 and RAS, which is not a good news for this patient. And when you monitor this patient, you see it's very important to see the patient in which you see a nice drop of KIT mutation to better than the one with no drop of KIT mutation, but look also at the clonal evolution of the subclone of the disease, because they may help you to decide which treatment we provide to the patient. So I think it is the last slide. So as I said, when you have a patient with advanced mastocytosis, make a good diagnosis of the HAN, consider at the beginning to make score, Mars score, try to find a donor for bone marrow transplantation if the patient is young enough. And then you have to decide which treatment you provide to the patient, and particularly avapritinib or midostaurin. Addition venetoclax is a trial if it starts, or in the real life if you have an HAN, and you may add also either chemotherapy or HNA. And then you follow the patient. If you see a drop of the systemic mastocytosis component and the HN component, you follow the patient. And then for the longer time, you have no clonal evolution, you can follow the patient. But if you see a worsening of the HN component, the increase of the subclones with the SRSF2, RONC1, SLX1, you may consider bone marrow transplantation for this patient. So I will stop here, and I will be happy to respond to your question.
Yeah. So thank you, Olivier, for this wonderful presentation. I don't know if there is some question. So maybe one about the hedgehog pathway. Do you start to use maybe Glasdegib or in vitro? I don't know in vivo, but
it's an interesting story, because we observe in one case report a young patient with a big head and 6 fingers, and with aggressive mastocytosis. So we said, okay, maybe there is some relationship between the big head, which is frequent in hematology actually, but this one is the patient has 6 fingers. And we look at the exome analysis, and we found that he has a mutation in the repressor GLI3R of the hedgehog pathway. So as a result, he has a high expression of GLI1 and GLI2, leading to high expression of MYC and BCL2, explaining why you have aggressive mastocytosis in addition to the X16 mutation. It has no TET2, no SRSF2, no SLX1, which is associated with older patients. So we show in this patient that he has a big proliferative component, and we took these cells, we blocked the hedgehog pathway, he went in complete response. But now we look at adult patient, and we look at the GLI3R expression and mutation. No mutation in this patient, but we have a downregulation of the GLI3R in patients with aggressive mastocytosis and also with HN component, probably due to epigenetic regulation of this protein, which play a role probably not for the proliferation, but we know it acts in synergy to activate the AKT pathway when you have a KIT mutation. And probably if we do block that, we may block BCL2, because BCL2 expression is linked to the hedgehog pathway, not to the KIT pathway like MCL1 and BCLXL. So if you block the hedgehog pathway, if you block KIT, eventually block BCL2, you will kill the cells and you will cure the patient. But now we treat in mice model, and we found very nice result with using this triple combination in mice, but we don't know yet in human, because we look at different kind of hedgehog pathway inhibitors. And the one which is working was held by Novartis, but they sold the drugs to the Australian companies that do not develop anymore the drugs. So we may use the one used in basal carcinoma in all patients, but it works less than the one, the Vismodegib, I think, is the best one, but is not in the market yet. But we try to push a company to put it back in the market.
Thank you. Yeah.
Yes, thank you. On a more practical point of view, will we be able to sort mast cells in comparison to other cells, eventually the T cells, and looking at mutation in the different compartments?
Yes. What Ludovic tried to do in Necker, when you have a patient with mastocytosis, we do a magnetic sorting of the cells with a kit. We don't use CD2 and CD25 because, as you said, you may take some T cells, but you won't reach with the KIT component with high expression, with the magnetic sorting. You may left over the progenitors, but they are not very important number. You can have an enrichment by 80% of the mast cells, and here you can look on the HGS, the different kind of mutation, and compared to the KIT negative population, in which you can make the difference between the two. This is a clonal evolution.
Olivier, very elegant story. Thank you. I'm currently treating a patient with a massive infiltration of aberrant mast cells in the bone marrow compartment. However, also a CMML, and by splitting those cells in the monocytes, there is no, say, KIT, but they have the other mutations. And what I not expected was that the patients rapidly progressed to a monocytic leukemia. And I'm working towards now to an allotransplant. So could you now argue that without the c-KIT in the monocytic compartment, the mast cell, although massive infiltration, is not the driver of the transformation to the monocytic leukemia?
What we have seen in 2 studies actually is that when you have a mast cell component, it may increase the proliferation of monocytes, but the risk of developing leukemia is less. Probably because when you have a mast cell component, you do see much better the monocyte component, and probably some monocytosis associated with a good prognosis are not seen in the regular population because you have no symptom, no cytopenia, and so on. But if you have a mastocytosis, you do see this patient probably because they have mast cell symptoms, or they have maybe proliferation due to the cytokine release by the mast cell component, which is not associated to the poor prognosis itself. So I don't know yet, but it's probably the hypothesis. But if monocyte has this SRSF2, SLX1, and ROX1, I think they have the same risk of transformation as the one without mastocytosis, I should say.
I do an induction with Fixios because I thought it is secondary to a leukemia. So I induce with Fixios and then go to a transplant. We're almost there. And in the remission, there was no CMML or monoblastic leukemia anymore. However, there was still a massive infiltration of the mast cells. Do you then argue that we should also target that component with the TKI, or?
No, it's what I do think. I mean, as I show that in most of the cases, I mean, in midostaurin, you have only 10% complete response, and you do see mast cell infiltration after the treatment. In avapritinib, it's probably less because we have 20–30% response. But here, I think if you block A16 mutation, the cell will survive. And probably because they rely on the survival of BCL2 or LJOG pathway, I don't know. So if you block BCL2 by venetoclax, you may see a drop of this mast cell component in the bone marrow. And probably because in the bone marrow, in the microenvironment, we have shown you have a lot of LJOG pathway ligand expression in the stroma, which may drive the survival of these cells in the bone marrow. For that, you don't see the improvement of and the complete response in mastocytosis.
Thank you.
Thank you, Olivier. If there is no more question, I think we could move to the next session.
Yes, thank you very much. So I will chair the session. So it's a busy session, collaborative biological studies, and I would like Olivier to be with us again and to stick on time, because targeting iron metabolism deregulation will be presented by Olivier. We try to make a common PowerPoint, but finally, it goes to Olivier. So thank you. And thank you again.
I didn't drink too much, so I hope I didn't. Let's say stupid things. So Michael asked me to provide you some slides to introduce the role of iron in MDS and in the context of new drugs development in MDS, and particularly in the low risk MDS. So you know, in it's a long work, but in erythroblast, you know, you need some iron for cell proliferation and also to make hemoglobin, but also for a lot of enzyme in the mitochondria to provide energy to the cell. So the classical view of iron in these cells is they bind through the transferrin receptor, the iron, which is bind to transferrin, and then it go to endosome, which release the iron. And here it may be stored in ferritin compartment, but also it may be used for the regulation of genes which are iron dependent, but also to go to different kind of enzymes, which are very important for the Krebs cycle and for oxygenation and so on. And then this iron may be released from the cells through the heme to the heme export here. And when you have no heme exporter, you may have an iron overload in the cell, leading to some ROS generation. And it has been shown also that the TFR2 receptor may bind iron, but probably the role of this receptor for iron uptake is very poor and very low. And there is some kind of discussion to see if the TFR here may regulate the signaling pathway of the EPO receptor. And actually, we found also, and we published a couple of years ago, that the transferrin receptor may bind also the transferrin, and depending on the saturation, it may act in synergy with the EPO receptor to induce the JAK-STAT pathway. And additionally, also, I think it's nice to be in this review that they show that our work we published in Nature that the IgA bind to the transferrin receptor. And when we published this paper, people said, "Are you crazy or what? IgA is to defend yourself against bacteria." And we said, "Okay, I don't know, but in the bone marrow, the polymeric IgA are the most frequent immunoglobulins." And we said, in the bone marrow, it's not an organ in which we have bacteria. So what is the role of IgA in the bone marrow? And we found that IgA, upon hypoxia, increase their expression to synergize with the EPO receptor, which may recruit more erythroid progenitors to go into cycle and to go into differentiation. And very interestingly, this IgA bind to the transferrin receptor to what we call the hinge region. And this region is unique to humans, only in humans, not in rat, not in mice. And to do this experiment, we have to do knock-in model in mice. But in one other species, it is present. It is in the, in English, I think it's the llama, the goat in the very high altitude, which may help them to have a higher level of hemoglobin to support like 4,000 meters of altitude. So I think IgA has been developed in the bone marrow to regulate the erythropoiesis, which is something that immunology doesn't like, and people working on erythropoiesis doesn't like either. But it's interesting because this IgA level may change in patients with MDS because of the inflammatory environment, because of the TGF-beta expression, which leads to this IgA, which may explain in some cases sometimes the early proliferation of erythroid progenitor. So it is the parenthesis here. So you see is what we do see, but it's more complicated that we do things the iron in these cells. And the main peptide which regulates the iron entry and release from macrophages to help erythropoiesis is what we call the hepcidin, which is very nicely and tightly regulated at the liver level. So what we know now that erythroid progenitors, early ones actually, produce an hormone which is called erythroferron. And erythroferron is able to bind and to compete with the BMP6 binding on the BMP6 receptor, which induce the SMAD pathway to lead to the expression of hepcidin. So I think here we understand why erythroferron is able to block the hepcidin expression is by competing with the BMP6 to bind to its own receptor. So during inflammation also, you may increase hepcidin through the JAK-STAT pathway, but the main driver is the SMAD pathway with BMP6 here. And then hepcidin is going to the ferroportin at the enterocyte level to induce this degradation by the proteasome and leading to reduced absorption of iron, and to the same thing in the macrophage, leading also to decrease the release of iron from the macrophages. So here it is what we know about the regulation of iron entry, which is very nicely coordinated because of the RFI here, because you can regulate your entry of iron depending on the erythroblast you need to make in case of anemia. And actually, it has been shown, for example, that EPO induce hepcidin, but it was not a direct effect, but it was an effect through the induction of erythroferron at the erythroid level. So this one is some work that we have done a couple of years ago, showing that, which was not expected, that the serotonin in the periphery and particularly in the bone marrow play a role in erythropoiesis. And we have shown that early progenitors depends for their proliferation from the interaction with serotonin and this receptor, which synergized with EPO to induce the proliferation of progenitors and reduce apoptosis. And when you knock out the periphery production of serotonin, or if you knock out the receptor of serotonin, you have my MDS model in this mice because they do express a lower erythroid production and they have some kind of ineffective erythropoiesis, showing that the serotonin may also regulate the sensitivity to EPO for the proliferation of these cells. So it was an interesting thing. And when you see patients taking some SSRE because they are depressed, and you do bone marrow transplantation, usually the length of aplasia is shorter by 2 days. And we did that in retrospective analysis, which is interesting for the patient. First, they are not depressed and they go faster outside the hospital, which is much better. So then in this model, we found something very strange when we knock out the serotonin. We found that the hepcidin level was increased in this the knockout mice and here in the liver, and as a result, we have an increased ferritin. So meaning that serotonin may regulate also the iron metabolism, which is something that we did not expect at the beginning. And when we took hepatocyte of this knockout mice, we see an increase also of the hepcidin. And in vitro, when we treat HBG2 cell line, which produce hepcidin with serotonin, we see a drop of the hepcidin production, meaning that serotonin may block the expression of hepcidin and may regulate the iron by this process. So then we try to understand where this hepcidin serotonin came from. And so we did several models of knockout mice with the receptor and the serotonin production in the periphery. And we did bone marrow transplantation with wild type in knockout, knockout in wild type, and knockout in knockout, and so on. So the conclusion, to be very simple, is that the serotonin coming from the enterocyte of the mice is going to the portal vein, I'm sorry, to block the hepcidin production. And we see an inverse correlation between the hepcidin level and the serotonin in the peripheral blood of patients. So here, and interestingly, we show, and I like to call this serotonin the enteroferron, because we knew for the long time that at the intestine level, there is something going to the liver to regulate the production of hepcidin. And it's probably, at least in part, the serotonin. And the model is the following, that in hypoxia, for example, it has been shown that depending on the HF2 alpha expression, you see a decrease of the hepcidin in the liver. And interestingly, we show that HF2 alpha increase the expression of TPH1, which synthesizes serotonin in the liver. So the serotonin go to the portal vein to repress here hepcidin production, probably by inducing MAP kinase, which blocks the SMAD migration into the nucleus of the cells upon BMP6 signaling pathway. And interestingly, also, we have found that the serotonin, the TPH1, which is the enzyme which produces serotonin, is regulated by iron. It's an iron-dependent enzyme, which explains also at this level a regulation where you have too much iron, you increase the serotonin, you decrease hepcidin, and you reprime the entry of iron. So here, probably, we may see and we may conclude that serotonin might be the enteroferron, and this paper is still under revision because it was very difficult to make new ideas, and hopefully will be out in a few months. So to come back to what we know, and as I said before, from the bone marrow, you know, and EPO may stimulate from the kidneys erythropoiesis, and erythroferron may reprime hepcidin, and hepcidin may allow the entry of iron and the release of iron from macrophages to allow the erythropoiesis to occur. But now, when we look at what we call ineffective erythropoiesis, which is, for me, the paradigm model is thalassemia, but in MDS, it's quite frequent also. And in most of the cases, this ineffective erythropoiesis is associated to an increased ROS level and the low fast ligand in the erythroid. So it's explained why the early erythroid progenitors are growing fast. And probably we have shown that the ROS may induce GDF11, and GDF11 don't regulate fast ligand. So anyway, so you see here, in ineffective erythropoiesis, you have more erythroferron, so you repress more hepcidin, so you have more iron entry, more iron release, which explains why the patient with ineffective erythropoiesis accumulate iron in the liver between all organs, and also probably in the bone marrow and also in the red cells. And I will come back to that in the future because I think it's very important at this level. They may lead to some complication and eventually transformation of MDS. So this work has been done by Michaela and her team, showing that in patients with MDS with SF3B1 mutation, I mean the sideroblastic anemia, and they have a high level of erythroferron because probably they have a high ineffective erythropoiesis, and as a result, you have high ferritin, which is expected, and you see also downregulation of hepcidin. So here it's a very good model of ineffective erythropoiesis regulating the level of erythroferron, leading to an increase of hepcidin. So here it is a model of what occurs in MDS with SF3B1 mutation. You see an increase of ERF, blocking hepcidin, which induces systemic hyperferritinemia. And to explain this feature, because sometimes the ineffective erythropoiesis and the number of red cells are not so high in sideroblastic anemia, Michaela and her team showed that the ERF genes present some mutation in the, if I don't make any mistake, in frame mutation, leading to an mRNA with high expression in these cells, and the protein resulting from this mutated mRNA provide a protein with a similar activity as a wild-type erythroferron. So here, this mutation may induce the stabilization of the mRNA from erythroferron, leading to the modified protein with the same ability to block and to repress hepcidin in the MG2 cell line. So which may explain why in SF1B1 MDS, you have more iron, more hyperferritinemia, which may lead to some complication in this patient. And interestingly, the iron, as you know, may play a critical role by generating some reactive oxygen species due to the Fenton reaction that you can see here. It's an old chemistry. And it's interesting because we say in the old textbook that iron and may provide some ROS here, but some chemists claim that this reaction cannot occur within the cells because the pH is not favorable to generate ROS, but it's a matter of discussion between specialists of chemistry. But anyway, this reaction may occur in some compartments in the cells, particularly in the lysosome, and I will come back to that at the end of my talk because it might be very important. So anyway, these ROS spaces may induce some genotoxic effect leading to some mutation and transformation of the cells. And we know also that ROS may induce some inflammation and may select some cells that we call of clonal hematopoiesis, and in turn, this monocyte also produce some inflammatory cytokines, which may lead to iron overload and so on, and you have some kind of a vicious circle here. And something that I like to see here is like this clonal hematopoiesis, which is selected probably with this iron overload and inflammation, lead to an increased risk of cardiovascular event. And interestingly, when we look at registry analysis of patients receiving iron chelation, you see that the death and the overall survival with no cardiovascular event in 34 months in the non-chelated patient when you compare to the 69 months with the chelated patients. And so it means that to use iron chelators may prevent some cardiovascular events in this patient, probably because you have maybe less ROS, less inflammation, and less recruitment of inflammatory monocyte, probably in the atherosclerosis lesion of this patient. And second of things which is interesting is the time to develop acute myelogenic transformation is reduced in patient receiving iron chelation. So I think we have to envision iron chelation not only as drugs to prevent hemochromatosis, secondary hemochromatosis, but more, I should say, to prevent cardiovascular event linked to the clonal hematopoiesis, and also to prevent the transformation of these cells. And I think it's some kind of a pity, I should say, that none of the laboratory wanted to assess specifically this question, and all of the registry studies show the same thing. I think it would be very interesting to have a randomized study with iron chelation, not only in low-risk patients in which they receive transfusion or have ineffective erythropoiesis to prevent iron overload, but in high-risk group to see if we can prevent cardiovascular event and also transformation into acute leukemia. So to prevent this iron overload in the cells, people wanted to use some fancy, I should say, drugs. First, it was antibody against erythroferron, which may lead to increase again hepcidin. And you can see here, interestingly, it works, and it improves also in some way the ineffective erythropoiesis, which is something that we have to understand, but it may improve also the hemoglobin level. And same thing when we use mini-hepcidin to overcome the high level of erythroferron, you see also an improvement of hemoglobin level in mice model, and also an improvement of the iron overload in this patient. So I think to target this iron metabolisms may help and improve erythropoiesis in this patient. So here is something I like to show. I come back to thalassemia, which is a very good model of ineffective erythropoiesis, in which you see the patient with a low ferritin level, they have no complications, I mean, except to receive transfusion, but they don't die of the disease. But the one with high level of ferritin, you know, like more like 800, most of them die within the 10 years period. So it has been very interesting to understand in thalassemia why this patient and how ferritin level is regulated. So obviously you have here too, like in MDS, and ineffective erythropoiesis, which is due to the presence of aggregate of alpha chains, which induce some ROS, and we have shown that this ROS may induce the production of GDF15 and GDF11, I'm sorry here, which in turn may block fast-fast ligand, and you may see the expansion of these cells, and they become sometimes tumoral cells, and because they go outside the bone marrow to invade the spine, for example. So it's interesting that this ROS, and probably in SF3B1 MDS, you have also an increase of ROS because of iron overload in the mitochondria. So this ROS, I think, may play a critical role to explain the ineffective erythropoiesis, the increased level of early erythroid progenitors, which in turn may produce erythroferron, which may regulate and aggravate the iron overload. So you know the story of the luspatercept to block GDF11 and also some other member of the TGF-beta pathway. And you see first in the thalassemia, it shows an improvement of the time to next transfusion, and something like 33% of the patients are not anymore transfused in transfusion-dependent patient. But something was very striking for me is when we looked at the ferritin level. Ferritin level dropped by 200 points, which is critical because remember the curve, and in the same time in the placebo it increased by 100. So you have a differences of 5 nanogram per ml of ferritin, which is high, very high. And if you expect, when you do see that, to see an improvement of the overall survival and the decrease of the comorbidities in this patient. But it was very surprising. Why it was very surprising? Because I don't think it's because only due to the reduction of the transfusion, the reduction of the ineffective erythropoiesis. Because when you look at the patient, for example, with the gene therapy, when you correct totally the ineffective erythropoiesis, they have no more transfusion. If you want to see a drop in ferritin level, you have to bleed this patient. Otherwise, the ferritin remains high. But here, whereas some patients remain transfused and they have a less extent of ineffective erythropoiesis, they have a drop, a massive drop of the ferritin level. So I think it's very interesting to understand what's going on here because it's not clear. And you know also the medalist trial, and we'll come back to that, showing that you can increase also the frequency of transfusion and dependency at 8 weeks. And here too, same thing, you see also a drop of the ferritin level when you compare to the placebo. And although these patients do not correct totally their ineffective erythropoiesis, some get still transfused. So it seems that it's something with the luspatercept which may regulate or modify the iron metabolism, besides the fact to reduce transfusion and besides the fact to correct ineffective erythropoiesis. So we looked at what's going on, and we try to, when you induce with BMP6 or an activin B, actually do the same thing. You induce the hepcidin level when you treat hepatocyte line here. And interestingly, when you induce BMP6 expression of the SMAD pathway and hepcidin, you see a decrease of this induction when you treat the cells with luspatercept. Well, probably it may block BMP6 at this level, which is totally counterintuitive because you may expect to see the reverse way if you see a decrease of the ferritin level. So when you do see that, you may expect to have a higher level of iron entry and higher level of iron release for the macrophages. But in fact, you see a drop of the ferritin level. So it's totally counterintuitive and difficult still to understand. And most interestingly, when we did the same experiment with IL-6, which induce the hepcidin through the JAK-STAT pathway, and you add luspatercept and you see a decrease of hepcidin. I don't know why, because it's not, you don't see the JAK-STAT decrease pathway. So probably there is some kind of steady state SMAD activation through the BMP2 or something like that you may block with luspatercept. So here you have a direct interaction, but when you look at the overall picture of the patient, you see the reverse way. And actually, when you look at the hepcidin level and erythroferron, you see an increase here of, I think it's erythroferron in the patient treated by luspatercept. So you may expect to see a higher level of ferritin, and you see as a consequence a decrease of hepcidin. But you do see a decrease of the ferritin level, which is not expected. So we have to understand what's going on. What are the hypotheses? And probably, I think that luspatercept may have a role directly to regulate the expression of ferritin independently of the iron pool within the cells, which is very important because it means that in this case, the iron which is bound to the ferritin might be released in the cells, might be free of any transporters, and may induce some kind of increased level of ROS, which might be toxic for the cells. But on the other hand, it may help to release the iron from the cells because you have an increased level of ferroportin because there's no more hepcidin. And in this case, in combination with iron chelation, you may see a better drop because the iron is not stored anymore in the ferritin. So it's something that we have to see. But the overall, what might be the benefits of these findings for the tissue, because you may expect, because you release too much iron, to be more toxic, to have more transformation, or in other way, if you see the delocalization of iron, it might be better for the organism. So here it is the summary of what I said. Probably the erythroferron, the luspatercept may play a role here that we don't know yet, but also I think in the macrophage directly and also probably in the erythroid cells. But interestingly, when you look, I think for the phase 2 study with luspatercept, the long follow-up, you see that the time to leukemia is reduced when you use luspatercept when you compare to the placebo, like in iron chelation. So maybe there is something like in the cells that play a role here. And I will finish to show you some work we are doing now. And when we look at the ineffective erythropoiesis, you see an increase of erythroid progenitors. And we show that the CD44 is highly expressed on this erythroblast during ineffective erythropoiesis. And very interesting, the group of Rafael Rodriguez in Curie Institute have shown that the CD44 may bind iron directly to make iron go into the cells. So it's interesting that you may see an increase of iron level within the erythroid progenitors, not because of the transferrin receptor expression, but because of the CD44 expression. But here, which is very interesting, is when the iron go through the CD44, it go to the lysosome. And at this level, it induces a lot of ROS. So probably the iron that go to the transferrin receptor is going to be captured by the ferritin, as there's no ROS generation. But here, when you have the high level of CD44, you may induce this ROS, which explains maybe the ineffective erythropoiesis and aggravates the ineffective erythropoiesis. So if you do block ferroptosis, because we know that this iron pool in the lysosome may induce some ferroptosis, you may improve the ineffective erythropoiesis. So what we generate some molecules, and I will tell you which one. And we were able, by blocking the ferroptosis, you see, to decrease the expansion of polychromatophiles in the bone marrow and increase the acidophils. So we do increase the maturation of erythroid cells when you have too much iron within them, which go to the CD44. And in mice with beta thalassemia in vivo, we see a totally different repartition of the iron pools in the organism of these cells. And you see an increase of the iron in the spleen and an increase also in thalassemia, you see you have an increase. But upon the treatment, you see a decrease in the spleen and you see an increase in the bone marrow, meaning that maybe we restore some iron pool for erythropoiesis and you see a decrease of ineffective erythropoiesis in the spleen, which is the location of ineffective erythropoiesis in mice. So I think by playing on the pool of iron, you may play a role in erythropoiesis. And actually what we did, we made a small compound, which is a derivative of the serotonin based on the work we have done before. I show you that this compound go in the lysosome to bind the iron at this level and to prevent the generation of ROS, which may lead to the improvement of erythropoiesis. So I think it's something that we have to revisit, actually, what we do know about the iron entry in the cells, because the entry to the CD44 is different to the entry by the transferrin receptor. And at this level, you may induce some ferroptosis, which may explain part of the ineffective erythropoiesis. So I will finish here and thank you for your attention.
Just one burning question. Otherwise, we are, yes.
There are many for isoforms. So do you know if this is a generic feature of CD44 or is it linked to specific CD44?
It is a very interesting question because that I don't know yet. You know, there's a lot of different splice of the CD44 mRNA generating different isoform of CD44 with different functions. And maybe, but I'm not sure, that in the SF3B1, maybe there is some alternative splicing of CD44, which may lead to an increased entry of iron to this compartment, leading to the sideroblastic anemia. So now we were doing some long-grain analysis of the CD44 to see the splice variant of CD44 to see if they explain more iron entry in the lysosome instead of transferrin receptors. So. I'm sorry?
So that's, I think it's the V7 isoform of CD44 is part of the XCT cysteine importer. So it would make sense for the cell to hardwire a system that both allows you to import iron and to have cysteine as antioxidant.
Very interesting to test.
So thank you very much, Olivier. Thank you. And we move to the second talk, Aline Renville and Christophe Wilkins, biological approaches looking for new therapeutic strategy in CMML. Pointer and the slide.
So we will try to be as good as Professor Hermine. I'm Christophe Wilkins from Gustave Roussy in France, and Aline Renville with me will present you the data that we obtained in the lab of Eric Solari, who is working on CMML. So as you may know, CMML is nearly all CMML patients harbor a mutation in a gene involved in epigenetic regulation. The most frequent being the TET2 mutation, which is responsible for DNA hypermethylation. So, DNA hypermethylation, you can treat the patient with HMA. And HMA are able to restore the DNA methylation status in responders, and is also able, as you know, to restore a transient functional hematopoiesis. Response to HMA correlates with survival and so on. The HMA are approved by the health authorities to treat MDS and CMML. But you know that with HMA, you are not able to cure the disease. You know that with HMA, even if the patient responds to treatment, you will have no impact on mutation allele burden. You will not prevent genetic evolution and transformation into AML. You are not able to predict the response before treatment, meaning that you will treat a large proportion of patients who will have no response, but they will have side effects. Honestly, the CR rate is low, between 10 and 20%. Overall response rate is higher, but we all want CR. And when the patient responds, the response duration is short. So to demonstrate the clear benefit of HMA in CMML, EMSCO designed a wonderful trial, a phase 3 trial comparing in the highest risk CMML patient decitabine versus hydroxyurea. And this trial showed no benefit of decitabine. Okay, it remains hydroxyurea. So for me, this trial clearly demonstrates that we need other treatment and we need to define other strategies. So in the lab of Eric Solari, we are working on different strategies to improve treatment, and I will present a short-term strategy which focus on the inflammatory mediators implied in the disease, the mature cells and the cytokine. So why targeting inflammation? You have to first keep in mind that the majority of CMML patients will die from CMML and not AML, or will die with CMML. Maybe you have 1/3 of patients in the highest risk patient who will have no CMML progression, but they will die. And maybe it's toxicity of the treatment, but I don't think it's only that. So there is something like probably inflammation that which is responsible for death in CMML. You have also to keep in mind that CMML affect older. You already know you know that, but is clearly a risk. Is clearly correlated to increased risk of cardiovascular disease. And CMML is also associated with systemic inflammatory symptoms and autoimmune disease. So it seems that we have to target inflammation in CMML. And if you assume the importance to target the inflammation, you have the second question is, who are the actors of inflammation in CMML? First, we know that an excess of clonal mature cells in CMML correlates with prognosis. You have a lot of mature cells and you will die. Okay, this is known for monocytes. As Dorothée said you yesterday, it's the same for immature granular cells. The more you have, the worse you will do. But it's also the case for mast cells, like Olivier Armin told you just a few minutes ago, but it's also the case for plasmacytoid dendritic cells. The more you have these mature cells, the worse you will do. We also know that in CMML, cytokines and chemokines are highly deregulated. And for some of them, like GM-CSF and IL-10, they will play a direct role in the pathophysiology of the disease. But they are also inflammatory mediators. And finally, we also know for some mature cells and some cytokines and some proteins that they are involved in a feedback loop between mature cells and the stem cells of the clone, and they will promote the disease. So it's clear for some cytokines. So it means that targeting mature cells and the cytokines could limit the inflammation-related symptoms, which is, I think, an important target for the patient, and also maybe to limit the CMML progression. So to illustrate that concept, I will talk about IL-8. IL-8, also known as CXCL8, is a chemokine implied in inflammation. IL-8 is the most upregulated cytokine in CMML patients. And high levels of IL-8 correlate with constitutional symptoms and also with excess of blast. So some features that are very important to treat. In the lab, Dorothée Selimoglu and her students have shown that in CMML, IL-8 is largely and mainly produced by the immature granular cells, but also by the monocytes. So IL-8 is highly deregulated and produced by the mature cells of the clone. And secondly, they showed that IL-8 is detrimental for the wild-type hematopoietic stem cells. So the IL-8 will limit the growth of these wild-type cells. But it seems that the CMML stem cells are insensitive to this IL-8. So IL produced by the mature cells of the clone will benefit to the stem cell. They are insensitive to the stem cells, to the CMML stem cell. And finally, they showed that when you treat the wild-type stem cells, which are the wild-type stem cells with they are with IL-8, and if you treat these cells, the wild-type cells, with the CXCR1, CXCR2 inhibitors, which are the main receptors for IL-8, you will restore their growth abilities. So altogether, these results show that targeting IL-8, which is an inflammatory chemokine produced by the mature cells of the clone, could be very interesting to promote the restoration of a wild-type hematopoiesis and a functional hematopoiesis, and maybe limits the progression of the CMML. So now I will let Aline showing you a second strategy.
Okay, so hello everyone. So in the second part of this talk, I will discuss the long-term strategies targeting the mutated clones or the leukemic state of the cells, which is very complementary to short-term strategies that Christophe just told you about. So I will first discuss the high-throughput screening approaches investigating novel genotype-specific therapeutic vulnerabilities in OXB8 cellular models. I will first explain what these models are. And I will also briefly discuss our preliminary data, very preliminary data about the CD47 agonist peptides that have been widely used in CLL, but now we are trying to investigate the potential of this work for CMML. So since there is given the lack of CMML models and especially the lack of cell line, I had the idea to leverage the OXBA system to try to generate a model of CMML. So what is the OXBA system? So it was originally described in 2006 in this Nature Method papers by Markham's group. And this system has been increasingly used by independent groups worldwide, and as you can appreciate by the increasing number of publications over the last 15 years. So how does this system work? So basically, we know that the transcription factor OXB8 is able to block the differentiation of cytokine-dependent murine hematopoietic progenitors. So this system is based on chimeric fusion protein with a hormone binding domain of the estrogen receptor that is fused to this OXB8 transcription factor. So when you overexpress this fusion protein in a myeloid progenitor, the cells are blocked and cannot differentiate and therefore proliferate indefinitely like a normal cell line. And when you remove the estradiol from the culture media, these cells can undergo normal differentiation and generate a wide range of different cell types, and depending on the cytokine you use to generate the model and also the cytokine used during the differentiation phase. So the SCF version of the model has been the most robust version of the model and the one that we are using. And in this version of the model, the cells are blocked in a GMP-like state. So what we did is to, so we took advantage of this system to generate different cell lines with the goal of modelizing CMML, or mainly the main mutations that co-occur in CMML, so namely TET2, SRSF2, and RAS. So we took different transgenic mice, TET2KO, TET2, SRSF2, P95H wild type, double mutant, and wild type controls, and we isolated the KIT-positive cells from the bone marrow of these animals, and then we infected these cells with a retrovirus expressing the ER-OXB8 fusion protein. And in the presence of SCF and estradiol in the culture media, we were able to generate these conditionally immortalized progenitors in a few weeks. So from there, we infected in a second step the double mutant, so TET2 SRSF2, with a lentivirus overexpressing NRAS G12D as a third genetic alteration to generate the triple mutant. So overall, we have 14 OXB8 cell lines, so 5 wild types, 3 TET2KO, 3 double mutant, and 3 triple mutant. And these models are supposed to mimic the stepwise acquisition of gene mutation in CMML, so typically TET2 first, then SRSF2, then RAS as a late genetic event. So what are we going to do with these models? So the plan for the next months and years is to perform a genetic screens targeting the druggable genome. And on the other hand, in parallel, we will do also high throughput drug screen using a drug repurposing strategy with a press-tweak chemical libraries, which includes about more than 1,500 molecules. So the goal obviously is to identify preferential genetic dependencies or drug sensitivities in mutated cells as compared to wild type cells. And ultimately, hopefully we'll find some interesting hits, and these hits will be revalidated in primary cells from CMML patients, and maybe potentially ultimately in PDX model for the most robust target. So obviously this is a very, it's a long-term project. So what are we doing also right now? We are testing a few drug candidates, including this CD47 agonist peptide, which works in a very different mechanism of action. It's nothing to do with magrolimab, since this peptide act as an agonist of the CD47 receptor, and they are thrombospodin-1 mimetic peptides. So these peptides are inducing programmed necrotic cell death through a mechanism that is not fully understood yet. It's different from apoptosis. What we know is that it's caspase independent, it's calcium mediated, and it's also PLC gamma 1 dependent and dependent also on protein G. So the efficacy of these molecules has been nicely shown in the context of CLL, both in vitro and in vivo. And what we are doing right now, we are trying to
assess the potential of this peptide in the context of CMML. So these are very preliminary data that we have generated over the last months. So on the left-hand side with our OXB8 model, and on the right-hand side with primary CMML monocytes. So on the left, so we expose the different cell lines. So in black, the wild type, blue, TET2KO, red, the double mutant, in green, the triple mutant. So as you can observe, the viability of the cells was significantly decreased in the double mutant and triple mutant, and with no significant effect in the wild type. So basically, it seems that the SRSF2 cells expressing the SRSF2 mutation are more sensitive to these drugs. So on the right-hand side, you can see this basically the same experiment, but here with a cell count with just basically with stripe and blue. So we expose the fresh primary monocyte to this drug. Then after 6 hours, we counted with stripe and blue the viable cells. So with no or very little effect in monocytes from age controls. And here on the right, you can see that in CMML monocyte, we have about a 50% decrease in viability. So which is quite interesting and has been quite reproducible over different experiments, but so how these patients mutated for TET2 and SRSF2? Some of them, but not all. So we still don't fully understand what are the determinants of response. And we would also like to check whether this effect can be also observed in other cell types, such as CD34 positive cells, which would be even more interesting. So this seems interesting enough, at least, to be pursued, and we are going to work on that in the next month. So just to conclude, so you're all convinced that there is a urgent need to improve therapeutic strategies in CMML. So as Christophe told you, so there is one approach that we can consider targeting the mature cells of the clone and the deregulated cytokines as IL-8, which could first limit inflammation and related symptoms, and as well as limit CMML progression by restoring wild-type HSCs. And in addition to that, because this therapeutic strategy is likely to be beneficial but unlikely to cure, we are also trying to investigate mutation-induced therapeutic vulnerabilities with the goal of potentially strike the disease at its root. So obviously, we are not as talented as Picasso, and so far we haven't found the right treatment yet, but at least we are working on it. So I would like to thank all our lab and our group at Gustave Roussy, both in the research unit that is led by Françoise Porto and Eric Solari, and the clinician from the hematology department at Gustave Roussy. And I'd like also to thank our external collaborators and, of course, the GFM and the GFM Center and the patient and physician from the GFM. And thank you for your attention.
Any question for Aline and Christophe? Just one question for Christophe. You mentioned that all the mature cells are involved in the production of cytokines, and so it may signify that it could be dependent on the mutation. So do you have any correlation with the high level of IL-8 and some particular mutation? If you accept that it is TET2 SRSF2, it could be the answer too.
Until now, there is no correlation between the gene status and IL-8, but maybe Dorothée can add some. It seems that I6L1 seems correlated with the levels of IL-8, but and it could be very interesting because it's the worst patient, but we have to decipher.
Since for Christophe, are other type of cells able to produce IL-8, like cells from microenvironment or others? That is.
The IL-8 is produced by many cells and also by some stromal cells. So we could think that also the regulation of stromal cells in CMML could also be implied in the overproduction of IL-8. But until now, we have not some data about that.
Olivier, question? No?
Yes, sir.
You focus your work on IL-8. Did you look at some other cytokines like L6, MCSF1, or TNF alpha, for example?
You know, there is the paper I showed from published by the teams of Padron, and then they showed that there is many cytokines deregulated, and they tried to make some correlation with many things, but TNF is also an important pathway, but until now we have not focused our work on that.
Thank you very much. We have to move on. Now it's communication from Daniel Novak, inhibition of lysyl oxidase synergized with 5-azacitidine to restore erythropoiesis in myelodysplastic neoplasm. Thank you, Daniel.
Hello, thank you for the invitation. I have to press in? Okay, now it works. Yeah, thanks for the invitation. I hope I can catch up a little bit of time, and I'm happy to talk about this project, inhibition of lysyl oxidases, together with 5-azacitidine for MDS. So the background is already almost 10 years ago, we showed in establishing xenograft models for MDS that the disease is highly dependent on the bone marrow microenvironment. It's not an isolated disease of hematopoiesis, but it interacts with the non-hematopoietic components of the bone marrow, both the cellular and also the non-cellular components. And at that time already we analyzed by RNA sequencing the differences of stroma cells derived from MDS patients as compared to healthy, and found some differentially regulated genes in these cells. And one of those target genes was LOXL2. So the lysyl oxidases have several isoforms, like 1, 2, 3, 4, and so on. And this was one of the interesting target genes upregulated in MSCs from MDS patients. And we followed up on this and also expanded it to other myeloid neoplasias such as CMML and MPN. We actually confirmed these results, that it's not only upregulated on gene expression level, but also on in bone marrow plasma levels. So in the microenvironment in the bone marrow. And this also translates into increased activity of these enzymes. It's also dependent, there's also a correlation between the bone marrow fibrosis, because what lysyl oxidases do, so these are enzymes that cross-link collagen fibers, and they get produced mainly by the stromal cells and released into the extracellular space in bone marrow and cross-link collagen fibers, and therefore most probably manipulate the extracellular matrix. And this is an indicator for this, that there may be a correlation between the activity and concentration and the grade of bone marrow fibrosis. And this is actually, you can analyze this in vitro. So you can culture these bone marrow stromal cells from healthy or MDS patients. They are plastic adherent. They form a cellular layer on plastic dishes. And interestingly, they also do their job there. So they deposit some an anorganic ECM, extracellular matrix, that if you remove the cells, if you decellularize this culture, then you have this ECM remaining in there. And when you look at this with an electron microscope, you can clearly see differences between these layers formed by healthy cells and MDS-derived cells. So we don't know what it means, but you don't need to be a morphology expert. It looks different. So this looks kind of softer. And this looks a little bit more hard and not so nice. And we have also analyzed these materials by electron force microscopy, so testing the stiffness of this material. And this material formed by MDS stroma cells is much more, it has a much higher stiffness than from normal stroma cells. So we know that change of the ECM disrupts hematopoietic differentiation. It interacts with all sorts of differentiation signaling, especially for erythropoiesis. And we were also wondering whether it might reduce the accessibility actually of drugs to the target cells. And luckily, so there's inhibitors available for LOX enzymes. Previously, there were antibodies, for example, produced by Gilead. And this there's a small company in Australia producing this orally available LOX inhibitor. It's actually a pan-LOX inhibitor. It inhibits all isoforms very efficiently. It's orally available, and it's actually also already in clinical phase 1 and early phase 2 trials. So there was a phase 1 study on healthy subjects to test toxicity issues, and currently there's an ongoing study in myelofibrosis. There's been over 10 patients included into there now, and this drug has a very favorable toxicity profile. That means it hardly has any toxic safety signals. It's, I mean, it has been tested on healthy people and nothing. There were not no alarming signals, and also here in these patients, there's actually no hematologic toxicity or anything that's highly relevant. So we performed this study to preclinical analysis to evaluate this drug in myeloid neoplasia. And the main points of this study was an ex vivo setup where we did the experiment I just showed you. So we derived cells from MDS patients, primary bone marrow samples from patients, culture these layers, and then perform co-cultures. So this whole experiment takes 10 days. We can culture these cells and treat them with PXS, the LOX inhibitor, pre-incubate these cells, wait until they are confluent, and then after 6 days, we had a 4-day co-culture period where we put the autologous CD34 plus cells from the patients on top of these cell layers, and then subsequently did a differentiation analysis, colony assays, and FACS analysis of the differentiated cells. That's the in vitro part. And then an in vivo part with MDS xenograft model where we also co-transplanted bone marrow-derived MSCs and hematopoietic cells into NSG mice, and then treated them with different conditions. So the conditions we chose is untreated control, 5-ASA alone as a standard treatment, the LOX inhibitor alone, and the combination of both. We worked exclusively with primary patient material, so over 30 patients, and you can see it's not only MDS, but there's also some CMML patients and even secondary AML in there. And also of note, many of these patients have been pre-treated, so these are not samples entirely from initial diagnosis, but they have also been derived after 5-ASA treatment, or some of them even after 5-ASA plus venetoclax. And we got quite a surprising result, for us surprising at least. So these results from the colony assays looked like this. And we found that neither control or the single substances really made a lot of change or response. But the surprising result was that the combination of the LOX inhibitor and 5-ASA really led to an increase of erythropoietic differentiation. So sometimes you could see it by eye in the pellets. And I think this is really remarkable to get this result in primary MDS cells that really don't grow well in vitro culture and even less even differentiate to get such a result. And this is also confirmed with FACS analyzing late erythropoietic differentiation with glycophorine A. So you can really see untreated and single substances don't really induce a great differentiation, but the combination does. So there's a great difference induced by this combination. And we analyzed this by FACS for all 30 patients. And what you see here is also here the conditions again, single substances and the combination. And the more red these fields are, the more erythropoietic differentiation we measured. And of course, you can see for 5-ASA, as we all know from real life, some of these cells respond. So there's a 5-ASA single substance response here, which we can also see here repeated in the combination. But additionally, in the combination, there's this field up here of over 30% of patients that exclusively responded to this combination while they did not respond to the single substances. And when you look at these responders, the fold change of erythropoietic cell production is highly synergistic. So it's not just 3 or 4-fold, but it's something between 5 and 20-fold in mean. So there's a real strong boost of erythropoiesis with this drug combination. This is also confirmed in the MDS xenograft model, where we have the advantage that we can treat the mice over several months. So these mice received a total of 3 cycles, standard cycles, 28-day cycles of 5-azacitidine, and constantly received the PXS, the LOX inhibitor, every day. And I'm sorry. So you can see this spleen size remained normal under the drug combination. This is the engraftment rate. So it's an sort of an indicator for disease activity, because the engraftment of these cells gets reduced under the combination. And most importantly, we performed serial exome sequencing. So we can bone marrow puncture the mice every 6 weeks, sort out the human CD45 plus cells, subject them to exome sequencing, and then follow MDS typical mutations, also with all the treatment conditions. And there are just some examples here of dominant mutations in those cells, which really strongly get reduced by the drug combination as compared to the single substances. And the interesting thing is this effect we can see induced by this drug combination is definitely dependent on contact of CD34 positive hematopoietic cells with the stroma. So if we do not add stroma cells to these experiments, nothing happens, there's no differentiation. But when we add the stroma cells, only then do we get this effect. So it's a genuine therapeutic treatment concept which needs the stroma, which is aimed at the stroma and not at the hematopoietic compartment. So to summarize this, I think these results very nicely showed that this combination is interesting for MDS because it really boosts erythropoiesis in comparison to the single substances. We could show in our xenograft model that it reduces disease burden and clone size. And it's really, I think it's one of the first bone marrow niche targeted therapies, which we could show by these experiments. And I didn't show everything now because it would be too long. So how do we continue from here? Of course, we found this result is surprising. We can't fully explain it. So now we are going into the mechanism of this synergistic effect. We want to find out whether it also works with decitabine. So these experiments are ongoing in our lab. We are just doing the same experiments again. I think it would be interesting also to evaluate oral HMA formulations, because then the patient could just take pills. And of course, now the most important thing is we want to translate this into a clinical trial. And we have designed a protocol to test this in the phase 1/2 trial together with the German MDS study group. So these are some of the leading members. And I think Uwe mentioned it yesterday already. So we need money for this. Unfortunately, the company is very small and does not have the funds. So we are currently applying, there's a German Cancer Aid, it's a large funding agency in Germany. The process started in January, and just a few weeks ago, I was there for the final evaluation. So we were successful in going through all these steps, and we will get an answer in December whether we will get funding. So I hope that we will get some support for this trial. And how did we design it? It's very easy. So the patients get 5-ASA as a backbone, I think, as in almost any trial for MDS. And they just don't get it at the beginning of a cycle. So a cycle starts with a 1-week pre-treatment of PXS. They just take it orally because this is very similar to our in vitro experiments. So there's sort of a pre-incubation with the LOX inhibitor. Then the patients get their standard treatment with 5-ASA, and they just continuously take the LOX inhibitor. We plan to do 6 cycles because, of course, we know that 5-ASA sometimes takes long to work. And there's a phase 1 to test dose escalation, and the phase 2 to test safety. So in the phase 1, we will test 2 different dosages, which we already know from these running trials of PXS. So they actually use 200 milligram, and we will escalate from 150 to 200 and determine the recommended phase 2 dose. There will be 6 to 12 patients included there with a modified 3+3 design where we can enroll patients more quickly. And of course, we will look at safety profile, pharmacokinetics and dynamics of the 2 substances. And then finally decide which of these dosages we can hopefully use in phase 2. And in phase 2, the primary objectives are also to determine the safety profile of this drug combination. And I think more interesting for us are the secondary objectives to look at response parameters such as hematological erythroid response, especially looking at whether how patients become transfusion independent. We will do this according to current response criteria, which were also applied in other studies looking at things like this. So inclusion criteria are also very easy. So because at the moment we don't really have any other treatment apart from 5-ASA for high-risk MDS patients, we will include all MDS and CMML patients with a German indication for 5-ASA. And that really also includes patients that transformed from a lower risk entities and have been pre-treated with other substances. And it also includes patients that have already been treated with 5-ASA or decitabine, albeit with a maximum of 6 cycles. So because the justification for this is our preclinical study has shown that even in those patients pre-treated with these substances, the combination can work. And we're including the 2 diseases because the response criteria are almost similar. This is all to really try to recruit the study as quickly as possible. Exclusion is also extremely simple, just standard things. The only things that are interesting to mention is we would exclude patients having been treated with this combination because our experience is that they are very far down the line, and history of aneurysm is an exclusion criteria specific to the LOX inhibitor, because of course there's the apprehension that if you inhibit enzymes that cross-link collagen, you affect the joint tissue of other parts of the body. However, in the currently running studies, there has never been an issue like this because things like the vessels or the organs and the joints, they have been preformed and they don't seem to be really affected by active LOX inhibition now in adult stage. So yeah, I think this is quite a sportive timeline. So once we get funding, we will submit everything to the new European portal and then go through the clinical phase 1 and 2 trials and evaluate the data. And we have calculated something like 52 months for this. within the cancer aid application, we have aimed for 6 centers. So it's a national German trial, which can, of course, be expanded by other centers that are interested. So, yeah, I'm finished with this, and I thank my team in the lab who has worked on this, and our cooperation partners, and especially also the people in my MDS study group in the clinic who have really worked hard in the last 2 years to design this protocol. Thank you very much.
Jan first.
Daniel, congratulations, impressive work. And if you are really able to make that translation of the clinic, it's really fun. So my first question is, your inclusion criteria is rather broad to speed up. But yesterday we spoke about that you can also lose your signal at the end if you have that so heterogeneous population for inclusion. Is that not a pity from the study? That's one question first, maybe a small answer.
I agree with you. It's quite broad with the intention to really ensure that we recruit. Yes. And as I said, the justification for even including pre-treated patients is that it worked in the preclinical study. I agree. Yeah, it's something the whole group has discussed a lot, and we've decided it like this. But it was a point of great discussion. Yeah.
Might be successful, but you have a pity. Secondly, the lowering of the tumor burden by the FAF decrease in your experimental model, that is not a result of the relative redistribution because of a restoration of normal, thereby lowering total, but from an absolute point of view, it's quite similar.
Yeah, so we also discussed this a lot. It's difficult to measure. I mean, what you would really want to answer is, do you have a reduction of blasts? Yeah, but we can't answer this morphologically in the mouse model. We can only look at it by immunophenotyping. So I didn't show this data, but we also measured CD33. So our data at least suggests that the immature myeloid cells get reduced by this treatment. So the CD33 positive cells get reduced, and erythroid cells, there's a change in relation. But we were not able to prove that there's really a reduction in blasts as seen morphologically.
Yes. Yes, congratulations. You nicely show that the LOX inhibitor needs the MSC component to be active. Have you checked the direct effect on this type of cells? And have you checked if a LOX inhibitor could change the exchange of material between hematopoietic cells and stromal cells?
So this is exactly what's ongoing now. So in our experiment, we checked the LOX inhibitor does really not affect hematopoietic cells alone. If you do not include the stroma cells, there's not a lot of effect. And of course, that's exactly what we're doing now. What happens to the stroma cells? What does it change in their gene expression and in their profile? What does it change in the exosomes they release into the supernatant? So we are looking into all of this right now. Yeah. Sorry.
Azacitidine alone is already able to change the MSC compartment, no?
Yes. Actually, indeed, yeah, we also have indicators for that. This is hypothesizing now. We believe that 5-ASA may not only be effective on hematopoietic cells, but it may also exert its effect on the stroma. There's also actually data from Katharina Götze from Munich who have shown this, that the hematopoietic cell may not be the only target cell of these substances. Yeah.
I have a question related to this one, because you showed in some experiments in methylcellulose and semi-solid cultures, but in this case, you show an increase of the number of colonies, the size of the colonies, and the differentiation of the colonies. But in this model, you use pure stem cells, or because there is no stromal cells, I mean the single colony, meaning that you have some compound that may diffuse in the methyl cellulose, or to explain the synergistic effect in the semi-solid medium, because you have no stromal cells in this model.
Yeah, so it's actually the cells, the experiment works like this. The stroma cells alone get pre-incubated for 6 days with the LOX inhibitor. Then they have a 4-day co-incubation phase where we take CD34 positive cells, which have been selected magnetically from bone marrow, patient bone marrow. And then they are taken from this assay into the methylcellulose assay, and there's no drug at all. So this effect is purely based on this pre-incubation.
Early stem cells, and do you know if you change the time of differentiation? Because if you do improve on the BFE, you may expect to see something at day 14, or if it's CFE at day 6, 7, or in your colony assays, you check the colony number at which time? 7 days, 14 days, 21 days, or
between 12 and 14 days.
Was the improvement at the BFE level, because it's 14 days or late BFE.
Yeah.
Okay.
Yes. Yeah.
So maybe you can check for maybe TGF beta member families, they may play a role at this level to explain both proliferation increase and differentiation increase, because usually it's some kind of a counter.
Yes, okay, thank you very much. So we are moving to the next talk, Lin-Pierre Zhao, MDS, CMML, and autoimmune and inflammatory diseases, excluding VEXAS. What relationship? Thank you.
Yes, thank you very much for the invitation. Actually, it was quite difficult not to talk about VEXAS syndrome in this context. So there will be a little bit about VEXAS data, but just a little bit. So my name is Lin-Pierre Zhao. I'm a physician. I work in St. Louis Hospital in Pierre Fenot's group, and I also work in Carl Balabagnan's lab that is in St. Louis Research Institute. So we are interested in systemic inflammatory and autoimmune disorders that are associated with myeloid neoplasm, that I think is an area that we are merely beginning to understand the biology and to characterize the phenotype of these patients. Also, this association has been known for a very long time. So I do not have any disclosures, and I will briefly present the context in which we are working, the features of these inflammatory disorders associated mostly with MDS and CMML. I will present our French minimum group, that is a collaborative group to study these patients, and present some published data and still ongoing research in VEXAS syndrome in the UBA1 non-mutated MDS CMML patients, and some data regarding the treatment. So in the scope of myeloid malignancies, we know that the association with SIAD mostly concerns MDS and CMML. This is something that we know for a long time, and we have recently reported notably that in pH-negative myeloproliferative neoplasms, the spectrum and the prevalence of these SIADs is very similar to that of the general population. We also have to bear in mind that these patients with inflammatory disorders, they may have received myelotoxic drugs, mainly methotrexate, azathioprine. So we have to be very careful about the chronology of these disease, because some of these patients may, in the secondly, develop therapy-related MDS. That is a complete other story. And then in the scope of MDS CMML patients who have clinical inflammatory symptoms, we now differentiate very clearly VEXAS syndrome from UBA1 non-mutated inflammatory disorders. And this is because the biology of VEXAS syndrome is very much well characterized today. But the UBA1 mutation do not explain the full spectrum of the SIAD associated with MDS and CMML. And so, as you can see here, we specifically screen in a cohort of MDS-CMML patients with inflammatory disorders and UBA1 mutations were only present in a small fraction of these patients. And I think that this illustrates only that we do not fully understand the biology and the genetic of this association for most of these patients. And in the scope of UBA1 non-mutated patients, there's just some features that I would like to introduce, 3 main characteristics that I think are very specific to these patients. The first one is that when we talk about systemic inflammatory and autoimmune diseases, it is mostly autoinflammation related to inflammation mediated by the innate immune cells. And in fact, we do really see very few lupus or pemphigus, for example, diseases that are directly linked to the pathogenicity of an autoantibody. Rather, it's very much more autoinflammation, and consistently the symptoms are systemic. It is mostly inflammatory arthritis, but also systemic vasculitis, connective tissue diseases. And 2 more important characteristics when you compare the MDS CMML associated with SIAD compared to idiopathic SIAD, there is a very high prevalence of unclassified and incomplete diagnosis, a typical form of these inflammatory symptoms. And perhaps the most important is the very high prevalence of refractoriness to conventional immunosuppressive therapies and steroid dependence. These are patients very difficult to treat regarding the inflammation. So to study these association between myeloid malignancies and systemic inflammatory and autoimmune disease, in France, we are part of a larger group that include hematologists, but also rheumatologists, internists, neurologists, cardiologists. The main goals of this group is to discuss difficult patient cases in multidisciplinary consultation meetings that we do in a monthly basis. And of course, to collect these data, to create database in VEXAS patients and UBA1 non-mutated SIAD. If I remember correctly, I think that we have in our database right now more than 500 patients with SIAD in UBA1 non-mutated patients and more than 300 VEXAS patients. Of course, we try to collect biosamples as well for these patients to foster research both on the clinical level and on the translational level. So here are just some examples of some work that our group has published, but you will see that there are many more ongoing projects and many much more work to do. So first, regarding VEXAS syndrome, you know that VEXAS is a progressive, severe autoinflammatory disease that is linked to UBN1 mutations. These mutations appear in the hematopoietic stem and progenitor cell compartments and are lineage restricted in the myeloid compartment. And these mutations are directly responsible for systemic inflammatory symptoms involving the skin, involving blood vessels and pulmonary symptoms and chondritis. So since the first description of VEXAS by David Beck in the New England in 2020, with 25 patients, we of course use these clinical data to describe the extended clinical phenotype of VEXAS patients. So here are just some examples regarding VEXAS-related chondritis. When we compare VEXAS-related chondritis to idiopathic relapsing chondritis, VEXAS patients had very specific phenotype. There were of course all male patients. They had higher fever and skin involvement, and much less involvement of nose chondritis and large airway tracheobronchial chondritis. Second example regarding the pulmonary involvement in VEXAS, we have known that the pulmonary involvement in VEXAS is very common, but most of the time is not severe, and in fact, very few patients will require oxygen. These alteration mostly concern the parenchyma of the lungs, and most of the time they are sensible to steroid, although they most of the time relapse when we taper the steroid dose. We, of course, are interested in MDS in the context of VEXAS. So one of the difficulties in VEXAS is to characterize the cytopenias that can be due to secondary to inflammation, to bone marrow failure, but also to MDS. And most of these VEXAS patients have a dysplasia in the bone marrow that meet the most basic criteria for MDS classification. So the association with MDS is very high in the retrospective series. Around half of the patients have MDS, but these are probably very atypical MDS with normal karyotype, low-risk diseases, and only half of them have additional somatic mutation that is very far from the classical MDS. So we are trying currently to characterize more deeply these MDS. And last but not least, some recent data regarding the inflammasome alteration in blood and tissue monocytes. So using deep phenotyping, cytokine profiling, and single gene expression, the authors basically found that monocytes were deeply altered quantitatively and qualitatively in VEXAS syndrome and displayed an aberrant chemokine receptor expression array. So this was in VEXAS patients, and in UBA1 non-mutated MDS CMML patients, we also tried to characterize the genomic landscape of these patients in a cohort of FT5 patients that we compare to a control cohort of patients without SIAD. The presence of SIAD was associated with lower risk disease with lower bone marrow blast percentage. And as previously described, the SIAD mostly concerned autoinflammatory symptoms with inflammatory arthritis and systemic vasculitis. The presence of SIAD did not impact overall survival or leukemia-free survival. And when we looked at the genomic landscape, we found that TET2, IDH mutations, and SRSF2 mutation were enriched in the patient with SIAD in both univariate and multivariate analysis, but without any specific commutation patterns. So now we think that these data, but also combined with data from other groups, suggest a common pathophysiology of the hematological phenotype and the inflammatory phenotype, because these somatic mutations, and this is much more well characterized in VEXAS, can differentiate into mature cells, and these mature cells, both in the myeloid and in the lymphoid arm, have increased inflammatory potential that in turn, this systemic inflammation will favor the outgrowth of the clonal cell within the bone marrow. This is much more well characterized in the VEXAS syndrome. What we are trying to look at the lab is the involvement of TET2 mutation in that setting. What we think is that TET2 do not directly create systemic inflammation, but when there is a systemic inflammation hit, TET2 will enhance largely this inflammation. When, for example, when we knock down TET2 in mouse model in the hematopoietic compartment, nothing happens in the inflammatory side. Of course, MDS and CMML develop, but when you stimulate the mice with a high fat diet, for example, for atherosclerosis, or cigarette smoke for COPD, these mice react much more severely in the tissue damage. So this is just a model. It needs experimental more proofs, but we are working on this, and maybe next year we will have more data. I think that to date, we have two main arguments to support this model. The first one is epidemiological. We know that clonal hematopoiesis, the pre-malignant state of MDS, is associated with a large array of inflammatory disorders, atherosclerosis, COPD, gout, liver fibrosis, but also autoimmune and inflammatory disorders. And we know from this paper also that was presented a little bit earlier that MDS-CMML patients also have an increased risk of basically exactly the same inflammatory disorders. So what I think is that systemic inflammatory and autoimmune disorders are just one part of a large array of inflammatory disorders associated with these myeloid malignancies. So this was the first argument, epidemiological. And the second argument is that if we assume that both diseases are linked to somatic mutations and mutated clones, we can assume that and speculate that by targeting the clone, we may be able to induce some remissions. So in MDS, to target the clones, we have, of course, stem cell transplantation. Unfortunately, it is only a few subset of patients are eligible for transplantation. We have targeted therapies, IDH inhibitors, for example, that are still under development. So the most commonly used drug that have an effect on the clonal burden is the hypomethylating agents. So we know from some case series and retrospective series that ASA have immunomodulatory effect. This was the largest retrospective series on 22 MDS CMML patients who had systemic autoinflammatory and autoimmune diseases. And the use of ASA led to inflammatory response in most of these patients. So this led to this prospective trial that was conducted by the French group of myelodysplastic syndrome, the GFM. And this was called the ESA-SIAD trial. It was a prospective single-arm phase 2 trial that treated high-risk MDS and CMML patients who had steroid-resistant and immunosuppressive refractory SIAD. And these patients received a full dose of ASA, and the efficacy was evaluated after 6 cycles. So this trial included 29 patients, of whom 12 were retrospectively found to have VEXA syndrome. So these are the only prospective data that we have to date in the treatment of VEXA syndrome. And what we found here, you have the forest plot of these patients with their outcome, and this is stratified by the presence or not of UBA1 mutation that you have in red, and the steroid decrease for these patients. And what we saw is that more than 2/3 of these patients responded, had an inflammatory response at 6 months, and nearly all the patients who responded on the inflammatory side also had a hematological response. And these, of course, this is not a comparative trial. We don't have a comparative arm, but these are rates of response in these patients who are multi-refractory to immunosuppressive agents, which is very high. And these responses were also sustained in time. So these were just some published data, but yeah, of course, there is a lot of work still to do. We are trying to characterize the association of MDS with autoimmune cytopenias, with renal involvement, with lupus as well. We are trying to evaluate the efficacy of IDH inhibitors in these patients, and also to perform exome sequencing in CMML associated with inflammatory disorders. And I think that the main message here is that, of course, if you want to collaborate, create new projects, we have these databases, and we are very happy to collaborate or just to discuss patient in the consultation meetings. As some perspective and beyond autoinflammation, what we are trying to do as well is just to characterize the immune profiling of MDS patients with 2 main messages, I think, that are important. The immune profile of this patient, we know that it evolves with time. This is a seminal paper regarding the regulatory T cells in MDS that evolves through the disease course. And this is recent data from Uwe Plasbeker's group showing that the inflammation state, the inflammasome, changes through the disease course as well. And the second message is that because the somatic mutations that appear in the hematopoietic stem and progenitor cells are compatible with differentiation, they can be found in all the differentiated cells in the lymphoid and myeloid arm. And basically, it can hijack and alter intrinsically the function, the maturation, and the phenotype of these cells. And we have some data regarding some correlation between the genotype and the phenotype of these cells, suggesting that the 2 mutation alters the phenotype and the function of natural killer cells, as well as the T cell repertoire. So we basically think that by combining these approaches, immune profiling, deep phenotyping, cytokine profiling, together with the genomic data that we have for this patient, we may be able to better characterize this disease. Okay, so I'd like to thank you for your attention. And of course, I'd like to thank the Minemon group that is help us a lot in these projects, the clinical department and the laboratory of hematology of St. Louis Hospital, and of course, our lab in St. Louis Research Institute. Thank you.
We have time for questions. Olivier?
Very interesting work. Do you know, because usually you say the SID or I don't know what, but do you split between real autoimmune disease versus auto-inflammatory disease, because it's different, and in most of the cases you have the two kind of disease, because probably, which is surprising actually, that inflammation do not lead to autoimmunity. So did you look at the profile of, for example, if you have an increase of TFH, for example, in patients with autoimmune disease versus the one with inflammatory disease, to explain the autoantibodies and so on?
I don't think we do not have any data regarding this. And as you said, most of the time is, I think most patient is autoinflammation related to myeloid cells. And we have really few evidence that adaptive immunity, T and B cells, are directly altered in this association. Yeah.
You know, a subgroup of patients with like clonal hematopoiesis with T2, IDH1 or DMT3A, with ILD, you know, like TFH proliferation, and with real autoantibodies in this case, and not auto-inflammatory disease.
My question is, can you do something to know about the history of inflammation, infection of your patients? Because it may change the presentation of their current disease you are looking at a given point. I mean, there is a lot of evidence coming from the mice models that in clonal hematopoiesis, maybe the NMT3 or TET2, you may have a different profile depending on the infection challenging and the repetition of the infection. So it may be important to know about, to better discriminate between patients.
Absolutely. I think that we absolutely have some experimental data, because I mean, it's more easy to monitor, and this is the infection data for patients. We do not have any data regarding this because I think it's very difficult to collect, actually. But it is definitely something that can affect.
Okay, Christophe.
Do you have data about some MDS patient with SID who transform into AML? Because I have the feeling that the patient who have transformation, they will not have, they will lose the phenotype, the inflammatory phenotype when they have a transformation, but maybe it's just the feeling. So do you have data about sequential patient before transformation and after transformation?
Unfortunately, we do not have some data. I don't have the impression that when from some case patient that we had, I don't have the impression that when they evolve, they lose their inflammatory phenotype. But yeah, definitely we do have clear data about this.
No, it was just a comment, because I think what Olympia is doing is very important, is to connect clinical manifestation with all this biology of disimmunity and auto-inflammatory and everything. And that I agree with Olympia. We saw some patients having really increased in auto-inflammatory phenotype during the progression. And as you say, some others, maybe low risk MDS, having different disease regarding the progression. And maybe we have to understand which kind of patient. UBA1 is just one part, and then the other part is hard to have this bulk. But maybe with this kind of work, we can have some subgroups. I think IDH1, IDH2 patients are particular patients, and it's important to progress in this concept.
So now I welcome Arjan van der Loestrich. We'll talk about MRD in MDS. Arjan and colleagues.
Michaela, thank you. And before the coffee break, I think everyone needs coffee. I would like to have a 50 minutes talk about MRD in MDS, and is it already time to implement in routine practice as well as to make clinical decisions on that respect. But actually what is minimal, actually the better word is measurable residual disease. And if you define that, that is actually the persistence of leukemic cells after therapy, mainly chemotherapy, and which numbers are below the sensitivity of our eyes, the microscope. So there are persistence, and therefore it's also the sum of the effects of all mechanisms, including the therapy, but also the microenvironmental conditions, the cellular resistance to specific drugs, etc., etc. And therefore it is a measure of the output after treatment. So what is left over, and it is detectable not anymore by the eye, but with a sensitivity by different methods. And within the minor diseases, and especially in AML, it is already well established. Within the new criteria of the European Leukemia Net 22, we define not only complete remission, but also complete remission without the detection of leukemic cells. So it's already incorporated. And but if we look now to the just recently revised response criteria in high-risk MDS, and you look to the scheme, most of you know already this scheme, the response is mainly based on the amount of blasts, but if you look carefully, don't look into too much details here, no concept is already there looking to minimal residual disease in high-risk MDS by whatever the method might be. So it's clearly not incorporated yet. And what is the reason for that? Because there are not really good data yet that in the mild spectrum of diseases from MDS towards leukemia, also minimal residual disease might be of relevance for clinical decision making. So what actually does it? It provides a quantitative methodology to go into a deeper remission state. It may refine our clinical decision post-treatment, and also very early relapse after conventional therapy or after an allogeneic transplantation might lead to clinical decision making. And also it can be used as a surrogate marker for drugs with potential interest. So there are a lot of compounds which are lined here. And there are several methods. Classically, we use the multi-parameter flow cytometry, and there are also other methods, but only the molecular method, there are robust data regarding specific mutations, such as the NPM1 mutation, the core binding factor, as well as the DRNX1 mutations, all done by quantitative PCR. These are robust, validated on several platforms, and may have clinical implications. The sensitivity of the flow is up to 1 cell out of 10,000 cells. A little bit higher for the quantitative PCR. And note, all other technical possibilities are not well established yet because the platforms are not harmonized yet. So these are the only two which might have now clinical implications in at least AML, but might be also in MDS. But whatever the method might be, here summarized either flow or quantitative PCR or even next generation sequencing, it is quite clear that both overall survival and event-free survival is always worth in those patients with MRD positivity, whatever the method is by definition. So there might be a really role to use that. And now focusing a little bit on flow, and what is actually, what are we doing with flow? We focus on the immature compartment. And what you can highlight here is that, for instance, a lymphoid marker on the level of CD34 positive cells is expressed to some extent, which is normally not expressed on CD34 positive cells and thereby aberrant. Or some antigens, which are normally highly conserved to be expressed on the CD34 compartment, are there or not, or are asynchronously expressed. So CD11b is normally a little bit later in the maturation stage expressed. So expression is abnormal and thereby different. Or the loss of CD33 on that specific population is lost and therefore aberrant. Or HLA-DR of others are overexpressed, all correlated to normal hematopoiesis. So thereby you can detect those leukemia-associated cells. And you can also combine that in MDS, high-risk MDS and AML. These are all data from our 7+3 schemes in our HOVON trials. So all include also high-risk MDS and AML. Therefore, I highlighted this explicitly. But note, if you combine next-generation sequencing platforms and flow cytometry, if these are both positive with a specific sensitivity, all those patients have a higher risk of relapse as compared to both negative measurements. And by combining not only the classical minimal residual disease assays focusing on only CD34 positive cells, as I highlighted you before, but include also the presence or absence of leukemia stem cells, so focusing also on the CD34 positive, CD38 negative subpopulations with an aberrant phenotype, you can add significantly in discriminating patients who are at high risk of relapse or not. So then we go to the clinical evidence that it's really working. So what we are currently doing, I showed you this slide yesterday, that on the backbone in high-risk MDS and AML, with or without an experimental drug, we follow the consolidation therapy based on MRD negativity or positivity, both in good risk as well as in intermediate risk, to either upgrade the intensification in good risk if MRD positive after course 2, or in intermediate risk, which we normally always lead to an allogeneic transplant, downgrade it to an autologous transplant in a setting of MRD negativity. And what are the clinical data supporting that? So in this trial, I showed you yesterday, there's no difference between the experimental arm and the 7+3 control arm. However, if you look to the good risk or the adverse risk, we show already that MRD positivity is always worse. However, if we guide treatment according to the scheme towards whether or not auto or allo, you see that normally in our previous studies, this was always the same as here, but now comes together. So that means that MRD guided therapy does have the same outcome as, for instance, an autologous transplant in some patients. So that's quite interesting. And there are a lot of models to further estimate or convince you that this is a good way of doing. But now MDS, what we have done over the past years, we have a lot of data on our HOVON trials, always the 7+3 backbone with or without an experimental drug, the mostly younger patients and something older patients. We grouped all those patients together and split them in AML as well as in MDS according to the definitions in those days of AP2, etc. And what I can appreciate here is if you look to overall survival on the left, on event-free survival and the cumulative incidence of relapse, MDS always do worse, as we expected. If you now zoom in to the MRD data, and we focus on the well-established method by flow in this case, on a harmonized, centralized backbone after the second course of therapy, and you look into details here, I appreciate to see that AML with MRD negativity do always the best regarding overall survival, as well as event-free survival and the cumulative incidence of relapse. And look, the MDS with MRD positivity after the second course are the worst one. Note, the numbers are lower because this is statistics also in that regard, and only 10 to 50% of the patients are MDS. But also this is very interesting. In patients who are AML MRD pos, do as bad or good as those MDS MRD negativity. So there is a discrepance. One question is, MDS is different from AML. we have to highlight that we do now all the molecular profiling. You can argue that these patients, okay, are the worst also by genetic definition. That could be. We are working on that, and we would see later on. But if you then also zoom in on the older patients only, over 60, that is not so old. However, in the protocols, we treat it differently. You see that we can really look to the outcome that if you are MRD positive, you do worse and very worse as compared to MRD negativity, highlighting the potential role also in high-risk MDS to use MRD in clinical routine practice. So last slides about other features, the leukemic stem cell burden at diagnosis, and it's all data published in a prospective data set of the HOVON 132 trial, 7+3 with or without lenalidomide, etc. So what you can also imagine appreciate here is that if there is a high frequency of leukemic stem cell load in the bone marrow compartment, those patients do worse. And if you then look after the second course, you have a similar picture. So beyond a very sensitive cutoff level, after course 2, the standard, which is most validated, leukemia stem cells does matter. If we then look to the combination after the second course, and we look to classical MRD methods as combined with the leukemic stem cell features, looking into the CD34 positive, CD38 negative, with or without the expression of CLL1 or other leukemic stem cell markers, you see that you can further increase the discrimination after the second course in outcome in this respect. Looking to lower risk MDS mainly, we did the same approach. And we look only to MDS with a low risk or intermediate risk profile according to the IPSS-R in those days. And looking then to the presence or absence of a aberrant stem cell phenotype, those patients do totally different regarding leukemic transformation, progressive disease, and even all-cause mortality. So that means with the leukemic stem cell tube, which is a highly sensitive method to look into aberrances on the stem cell level, you can discriminate also in low-risk MDS the clinical outcome. Finally, are we also able with flow cytometry to follow the patient? So there's a little different story as MRD, because then focusing only on leukemic stem cells or on the CD34 positive blast. But within a clinical trial, looking into both non-del(5q) and del(5q) with or without lenalidomide, or sorry, always with lenalidomide, with or without additional ESAs. And you look into several time points, basically starting at point 0 and looking after response defined by hematological improvement, you can see here that in some cases, some parameters fully normalize. That means that by flow cytometry, and looking here mainly in the erythroid lineages, normalization of erythropoiesis mimics also of parallels hematological improvement. And if you look also to other compartments, the monocytic compartment, as well as the neutrophil scatter, which is a sign of hypogranularity under the microscope, in responding patients, there's a significantly normalization of the aberrant dysplastic hematopoiesis, not only on the erythroid lineages, but also on the myelogranulocytic lineages. So to summarize on this subject, and this is a very interesting review, which is just published by Sylvia Freeman and others, and you look to the spectrum of clonal diseases towards AML, I showed you that we can apply nowadays, established in AML, the use of MRD monitoring on a standardized platform, which can also be done in high-risk MDS as a continuum. I show you some data supporting that in high-risk MDS. Based on prospective studies, it's quite the same. And also in the UK, there are some data supporting this in a retrospective data set. I showed you that the addition of the aberrant stem cell features might add significantly to the discrimination of classical MRD in adjunction to leukemic stem cell MRD. And that is also translated to a more low-risk profile. And at the end, a little bit different, is that normalization of the MDS dysplasia scores. I showed you a little bit on the prospective HOFON trial, but also others have some notations. Normalization is also a method which might be useful to look into more detailed in responders of not responsive patients, as well as to withhold potential cytotoxic drugs from the patients if no normalization has been reached. We just discussed it yesterday a little bit, but also this technique can, if validated prospectively, if we get more data, in this way we can use also this kind of disease monitoring, a little bit different from classical MRD. So with that, I would like to close and thank the primarily MRD group at my hospital, led by Jacqueline Kloos. And Lok Lam is evaluating all the MRD and MDS data specifically, and the MDS team. And most of you know these people from my lab. Thank you for your attention.
New data and a very active group. Okay.
Okay, thank you. I have a question. Definition of MDS in your first slides, high-risk MDS, AML, intensive chemo. You showed basically the outcome is worse than AML, right? This was your conclusion. So which means the ICC is not right because MDS is even something worse than AML. Sorry, I'm a little bit provocative here. So was it like only blast based, like 11 to 19% blast, or was it like excluding NPM1 mutation, these kind of things? So what is your explanation for that?
For now, I can say that it was based on the older definition of the classification based on EP1 or EP2, so the 10% threshold. In the final last year's HOFON trial, so from 3-4 years ago, we already included the IPSR over 4.5 as the cutoff. So that is mostly could be independent from blast cell count, but then based on cytogenetics, etc. What we are now doing is to explore retrospectively, therefore, whether or not that were in the WHO 2022, as well as in ICC definitions, how could we retrospectively score these patients? And then I get the final answer on your question. Is it really an MDS now based on specific AML-defined features and therefore appropriately defined, or really MDS features? I hope to mature the data and then answer the question more precisely.
Very nice work. I have a question about the use of MRD, because in some other disease, when we do, for example, a maintenance therapy, more we do and more we do see that patients that benefit the most of are the patients who are MRD negative instead of MRD positive, which is sometimes counterintuitive. So do you think that in MDS or AML MDS, after treatment, if you reach MRD negativity, instead to stop the treatment, you should add some maintenance therapy, for example, with oral azacitidine in this group of patients versus the one who are not responding. In fact, they might not benefit of maintenance therapy.
I fully agree. And so actually we tried, but failed to interfere mainly in the intermediate higher risk group, if MRD positive, to also switch to a MRD negative state before going to an allo transplant. And we tried to do a trial with tagoflusumab, the anti-CD123, but we could not make it at the end. That was really touching on that question. And then only try to reverse MRD positivity before going to an allo transplant. So at the time, that should be the answer. That could be a strategy. What also is possible is to use it post-allo. to have a quick reduction in immunosuppressive therapy if there is still ongoing MRD positivity, either by molecular technology or by flow of whatever. And then oral ASA in a maintenance setting could be a very good proposal.
But it should be interesting to check and evaluate if the patient who are MRD negative, in fact, may respond better than the one who are MRD positive.
Right. Yeah.
Okay, thank you very much. I know there is other questions, but we must stop there. There is a very quick, thank you very much, Ariane, very quick coffee break. For those who have not checked out, please do it right now. And we will be back at 11:05. 11:05. Okay, so we could start now the discussion about unmet needs, future clinical trials, future fundamental research. So the first talk will be given by Daniel Novak and me about therapeutical targeting R loops, therapeutically targeting of R loops and replication stress in splicing factor mutated MDS. So thank you, Daniel.
Hello. Yeah, again, thank you for the invitation for this talk, and it's a great honor for me to give this presentation together with Dr. Fontenay. So what is this about, R loops and splice factor mutated MDS? So ever since the spliceosome mutations have been discovered in MDS, we actually know that these are one of the most common mutations in MDS. They represent over 50%. They are special, so even in MDS with ring sideroblasts, they are even enriched to almost 80 or even 90%. Many studies have shown that these are early mutations, so-called founder or driver mutations, and they have some special things about them. They are mutually exclusive. That means usually there's no two spliceosome mutations occurring at the same time in the same cell. They are heterozygous most of the time, and this leads to the annotation that they are so-called gain of function mutations. So they don't destroy the function of the genes, but they modify it or change it. And this has very early called up the hope and the vision that there may be a unifying pathomechanism exerted by these mutations, enabling synthetic lethality concept for MDS treatment. And this has sparked some very nice preclinical experimental studies in the last years, which have actually proven this concept in vitro and animal experiments sometimes. And the underlying mechanism is that spliceosome mutations lead to so-called R loops. This induces replicative stress, and this in turn induces genomic instability, which can be targeted by drugs that inhibit DNA repair. And I will elaborate on this in the next few slides to explain this a little bit. So these the spliceosome mutations lead to disturbance of normal splicing, and this means that mRNA transcripts are produced with a lot of mistakes, such as intron retention, for example. And these mistakenly produced mRNA transcripts hybridize themselves into the replication fork of DNA. And when this happens, this is what is called an R loop. And this leads to a slowing down of the replication and accumulation of DNA damage by the induction of replicative stress. And this in turn induces DNA repair mechanisms. And synthetic lethality concept means that you can actually inhibit these DNA repair mechanisms in the sense that the spliceosome mutations give the cell one hit. So over some ways it gives them an advantage, but it also gives them a disadvantage. And if we disturb this mechanism at a second point, then the cell actually gets too much of this pathomechanism, and this leads to its death. So one target substance, for example, is ATR inhibition. It's one of the most upstream molecules in this DNA repair pathway. And this is, for example, the results of our studies, which has shown this in proof of principle. So here you can actually see, you can visualize R loops by an antibody against S9.6, stain these stalled replication forks and R loops within cells. And here's the proof of principle that CD34 positive cells from primary MDS patient cells actually really do contain more of these R loops if they contain splice factor mutations as compared to MDS patients that do not have splice factor mutations. And we used an ATR inhibitor from AstraZeneca. It's currently also in early clinical phase analysis. And this summarized data shows that there's really a higher sensitivity of splice factor mutated cells than cells that are not splice factor mutated or healthy cells. So as you can see, this is also primary patient material again, so the numbers are not super great, but the effect is clearly visible. And but already in this study, we had the observation that there may actually be differences within the splice factor mutations. So this hope or vision that there would be a unified mechanism and we don't have to think a lot about it. I don't know whether it's true. And unfortunately, the study was not powered to ask this question. For example, here you can see that we have one ZRSR2 mutated sample in this study, and that doesn't have a lot of R loops at all. So, and there's also quantitative differences between the different splice factor mutations. They reacted similarly, but I have to admit the sample number is quite low, and yeah, the proof of principle is shown. But the question whether different splice factor mutations are different from each other is not really answered. So these are the open questions currently. Are they all the same? And then, of course, what role do co-mutations in those cells play? Which is the actual target cell? Is it the stem cell or the differentiated progeny from these? Is an RTA inhibitor the best substance? Because there's a lot of groups internationally using other substances to address this hypothesis, for example, PARP inhibitors and other things. To my knowledge, nobody has really shown yet whether it really leads to a targeted depletion of splice factor mutated cells. This would have to be done in an in vivo model, which you can treat longer term. So these are the current approaches in my group. We are trying to establish models where we can knock in and knock out these splice factor mutations. We did a in silico expression analysis in publicly available databases. We're actually transplanting these patients into the xenograft model to check whether there's a clonal targetability for these substances. And we're also asking the questions, are there better or other substances other than ATR inhibitors with a drug-screen, a droplet microarray technology? So these are first initial results from cell lines. We transfected cell lines with the different splice factor mutations here, SRSF2, U2AF1, and SF3B1. And here you can already see it confirmed that they, for these two spliceosome mutations, they still have a higher sensitivity for ATR inhibition. But the SF3B1 mutation, which you know has a much better prognosis in MDS, behaves the completely opposite. So in this model, the splice factor mutations do not behave the same. And this is the result of the in silico analysis, where we took available public data in AML in this case, but which also carry these spliceosome factor mutations. Checked using predictability models what sort of drugs would also be candidate substances for our splice factor mutated cells. And yeah, there's a list of other attractive substances, for example, CDK inhibitors in both cohorts, PARP inhibitors. And the interesting thing is that a lot of these substances which were predicted by these pipelines are already currently in evaluation. So last ASH, it was actually full of abstracts and talks checking different substances on splice factor mutated MDS, such as PARP inhibitors, CHEK1 inhibitors, WEE1 inhibitors, MEK inhibitors. They're all predicted by this pipeline, and many groups have also had this idea already, and this is in ongoing evaluation. We can actually show some own data from for CDK inhibitors. So this is from another project where we analyzed over 40 high-risk MDS patients, also primary samples, to check the CDK9 inhibitor alvocidib in combination with 5-AZA, which actually leads to some very nice additive effect, and we genotype these cells in sort of biomarkers. And here, breaking down for the presence of spliceosome mutations, we actually found that for ZRSR2, This could be a predictive biomarker for response for this CDK9 inhibitor. So this is all primary cells, and the sensitivity seems obvious and significant, but not for the other two. So here you have to consider ZRSR2 they are quite rare mutations for MDS, but nevertheless, it's interesting, and it confirms that different mutations can confer special sensitivity for certain substances. So since for primary material, there's always the limit that you don't have a lot of cells. So we are pursuing a cooperation with the Karlsruhe Institute of Technology. They have developed this micro tissue culture microarray where you put cell cultures into droplets, and we can reduce the MDS cell count, which we have to put into one of these droplets, from 1,000 to 200. So this considerably enables us to screen more substances. This is also ongoing, but results are comparable with micro titer plates. So I think this is an elegant method to really also perform drug screening in primary MDS samples. And these are the patient samples we have currently transplanted into mice, but we don't have results yet. So this is ongoing. And yeah, that's my approach. And now I would like to hand over to Dr. Fontenay, who has also a lot of interesting experiments and is addressing interesting mechanisms in erythropoiesis.
Thank you, Daniel. So I will take sorry. Okay, so I think the question is there. Do the splicing factor are the splicing factor doing the same? But we already know that the splicing factor which are currently mutated in MDS are playing different role in the spliceosome. For instance, SF3B1 is recognizing the branch point. U2EF1 is defining the intron sequence at the EJ site, and SRSF2 is mostly regulated the intensity of splicing by the binding to specific exon sequence. And it is already known, and we have this nice RNA-seq data showing that the splicing events are different according to the splicing factor mutant. And for instance, you can see in green that SF3B1 is mainly doing loss of intron retention, and also is making some 3' alternative junction compared to SRSF2 or U2EF1, in which we observe mainly cassette exon. So there is difference. So what is important there is the fact that during erythropoiesis, there is a way to obtain specialized cells by retaining introns. So this is something well described, that during the differentiation, the cells are retaining introns to modify their capacity and their behavior. So it may be very important for the erythropoiesis in MDS with SF3B1 mutation to address the question, what is the impact of reduced retained introns? So to address this question, we derive from CD34 positive cells erythroblasts from patients. We made a lot of different experiments, and we perform both RNA-seq and proteomics analysis. And in RNA-seq, you can see nicely that there is indeed also a loss of retained introns, so it's always a green bar, that is increasing during the differentiation between the basophilic and the polychromatophilic erythroblasts. And it is quite important to see also that the RNAs that are modified by the loss of retained intron are involved in DNA damage response and also in the regulation of the mitotic cell cycle. So it may be important, and it was interesting also to see that it correlates with the maintenance of proliferation of such mutated cell in vitro compared to the normal counterpart. So what is the importance of splicing? So it was shown for a while by Jim Manley, and more recently by Benoit Palancade, a yeast guy with whom we are collaborating, that the splicing of introns is a way to prevent the genetic instability due to the formation of R-loop. As Daniel mentioned, if you retain sequences that are able to hybridize with template DNA, you may increase the probability to form R-loop. And to address this question, because we hypothesize that reducing retained intron could diminish the probability of forming R-loop, we perform in primary cell, and it's quite challenging, DRIP-seq experiment. Well, what is DRIP-seq? It's a sort of ChIP-seq using S9.6 antibody to immunoprecipitate the R-loop, specifically at the level of DNA. So we don't have contamination with RNA-RNA hybrids. And what we saw when SF3B1 is mutated, it is a reduction of the number of peaks and also the intensity of the peaks. And it was quite interesting. We have the possibility to quantify that, and you can see that the number of peaks is really reduced in SF3B1 mutant cells. So it is important also to notice that this technique is able to localize the R-loops, and we lost the R-loops mostly at promoters, but also in gene bodies. And this is something quite different from what has been observed in SRSF2 mutant, published, as I mentioned, by Daniel in 2018. In this paper with SRSF2 mutants, there was an increase of R-loop at promoters, especially. But here we lost the R-loop at promoters and in gene bodies. And there was quite a significant overlap with the gene with reduced intron retention. So it may go in the good direction, showing that the loss of R-loop could be at least partly due to the reduction of intron retention. So R-loops are usually obstacle to DNA replication. So you have in yellow the replisome, and the replisome may be arrested in the formation of replication fork by the transcription that is occurring quite in the vicinity, and in particular if R-loop form when the transcription progress. So it may have the formation of R-loop may have an impact on the replication stress. So what is replication stress? It is the way the cell is replicating. Is it, are the forks going too fast or too slow? Usually when we talk about replication stress, we talk about fork that stall when they encounter an obstacle. But here what we saw is the fact that there is an increase of proliferation and increase of incorporation, increase incorporation of BRDU, showing that there is an increased DNA synthesis, and also the length of the tracks labeled during the combing experiment increased, so meaning that there is a possibility that the forks are going too fast, and this is quantified on the right, and with preserved symmetry, so meaning that starting from an origin, the forks are progressing the same in the two directions without encountering obstacles. So if there is a possibility to go fast, is there DNA damage? We only notice in erythroid cells that there is single cell DNA exposure and no evidence of double strand break, usually labeled by the gamma H2X. So it's quite different when you compare SRSF2 and SF3B1. And of course, this is a quite specific picture related to SF3B1. And finally, we know from the recent literature from people working for a while on R-loops that histone deacetylase activity is necessary to prevent the formation of R-loop or to resolve R-loop. And if you use an inhibitor of histone deacetylase, you may help the formation of R-loop. So we use such a drug, and we perform again DRIP-seq experiments. And you can see here, depending on the genetic background, that you may rescue the formation of R-loop in SF3B1 mutated erythroblast, but no effect on MDS with no splicing factor mutation and no modification of the pattern in case of SRSF2 mutation. So indeed, what is it interesting to may think about this drug? We perform erythroid cell maturation experiments, and we can see here that there is an increase of GPA positive CD49D low cells, meaning that the cells are maturing with the drug when SF3B1 is mutated. And this is also visible on the MGG slides. And we have a reduction of S-phase cells without a major DNA damage provoked by the drug. So finally, I have this conclusion that is proposed by Daniel, that SF mutation have high potential for new molecularly targeted treatment concept in MDS. More preclinically characterization and differentiation of the splicing factor-induced pathomechanism in MDS is necessary to develop robust stratification concept for future clinical trials. Both the biology of single splicing factor mutation and the co-mutation profile seem to be relevant parameters for therapeutical targeting splicing factor mutation, and cellular differentiation stage seems to be relevant for the SF-mediated molecular mechanism. Thank you. So do you have questions?
Yes, it's very interesting. One of my general question is when you look at the splicing factors alterations and you see that you have maybe some replication dysfunctions and which may induce some expression dysfunction. Do you think it's because of abnormal DNA replication that you may induce some kind of reparation genes and the p53 expression, for example, which may lead to some kind of maturation arrest and growth replication arrest? Or do you think there is some specific genes which are not expressed because of the splicing abnormalities, which may block the differentiation? So it's more like a general mechanisms of replication or specific genes which are involved in the maturation of erythroid cells?
It's a very good question. So we have, the answer is probably both. Yes, if you are looking at the gene and the proteins that are modified by the presence of the mutation, we have indeed modification in the expression of crucial factor for the regulation of spliceosome. So, but it depends on the splicing events. So it's a direct consequence of the mutation. I will not give example because we are still working on it, but we have evidence for the deregulation of specific factors that are really important for the maintenance of a good replication way and the control of replication.
The interesting presentation. So I just have a question with regards to the mechanism why spliceosome mutations occur mutually exclusive in the majority. I mean, also in the clinic, you have either one, but not a combination. Is there maybe the excessive formation of R loops the reason why this cannot occur? I mean, have you done experiments where you basically introduced another spliceosome mutation?
Yeah, so this is actually a very important question because it also makes experiments, these mutations, difficult. For example, first, we tried over half a year to introduce spliceosome mutations into cell lines by CRISPR-Cas to get the physiological situation. But the cells did not accept these mutations because they obviously already have other hits, so to say, which go into the same pathomechanism. And if you introduce a second one, that's the answer why they are mutually exclusive. The cell can only take a certain dosage of this problem, if I can simplify it like this. And that's the concept behind the synthetic lethality. But it's complete. So I don't know. You'd have to find the other mechanism that's already there, why the cell does not accept the mutation. And that's the conclusion here of this talk. This initial euphoria that we have an easy, accessible, common pathomechanism by spliceosome mutations. That doesn't seem to be the case, because the deeper you dig here, and I mean, partly these results seem contradictory. Yeah, as of 3v1 mutations, suddenly we have less R loops, we have increased fork speed, while in our study we had reduced fork speed for the majority of the spliceosome mutations. So I think this, unfortunately, it has to be investigated much more in detail.
I do think that the commutational profile and the commutation are very important to interpret the data, because if you have only SF3B1 mutation, okay, you can say something, but the commutation, because currently there is some new papers on the market showing that, for instance, IDH mutation is provoking R loops, and also the complete invalidation in mice model of the TET1, TET2, TET3 is also provoking R loops. So there is a lot of different condition. Okay, so.
Another one. In line with the lot inhibitor story, does the stromal cells impact the response to treatment by splicing factor modulators?
Investigated this yet? No.
If there is no question, we can move on. And there is a little change in the order, and Dr. Alexander Ozer will be present Common Artificial Intelligence projects in MDS. Yes.
Okay. Thank you so much. And for the shift, it's just because I have to take the plane. Sorry. Oh no, this is the wrong presentation. Yes, that's the right one. Thank you. So yes, my name is Alexander Ozer. I'm from the University Hospital Leipzig, an associated center, which is called the Innovation Center Computer Assisted Surgery, where we focus not very much on surgery these days, but on everything but surgery. And most of the time focusing on artificial intelligence methods in hematology, at least in my group. And today I want to present some kind of state of the art about some recent developments in the field. And I want to also spark some discussion or maybe some inspiration for collaborative projects within the EMSCO and beyond. And maybe also assess some potential for specific scalability of existing approaches or the development of new approaches. So I classified this talk into 4 dedicated subjects, which is diagnostic assistance, it's outcome and risk assessment, clinical trial support, and patient support and beyond. First, for the diagnostic assistance, there has been a lot of work recently in the field focusing on using image-based AI methods for cell classification, for the assessment of morphological changes in those cell classifications. And of course, when you have a classified cell, then it's very easy to count it and to derive also, like, for example, WHO classifications or specific subtypes of the disease you are investigating. And those approaches are basically mostly used on a specific set of algorithms, mostly referred to as deep learning. There are many subjects focusing or addressing different methodological algorithms. And I think that this field is very good represented in the current research landscape. It might make sense to use those kind of approaches to scale, because most of those papers and submissions mostly focus on data that was observed on 1 or 2 sites. But if you combine it with a more broader approach, it might also lead to more generalizable results, which would make the life of the medical stuff much easier in the future. I think this is very close to solutions that will be broadly accessible also in clinical practice very soon. So there's a lot of opportunity, of course. You can speed up processes. You can make diagnostic and classification processes much safer. You can speed up the workflows. But of course, in the end, it's very well working with combinations that are more common because there's a lot of data. And when there are rare cases, the algorithms and systems are most likely to fail, which would introduce the hematologic expert again to make those detailed classifications. In the case of AI for outcome and risk assessment, there has also been some very well represented work in the last couple of months. For example, in the case of predicting therapeutic outcomes while using routinely assessed data instead of waiting for the actual event to occur. In this case, in hypomethylating agents, but also in specific drugs, like for example here in azacitidine, which is basically just a work that aims to predict the outcome before the 6-month mark and to stratify those patients based on their risk profile, whether they will respond well to the treatment or not well to the treatment. We've also, beforehand, there's a lot of potential in those kind of research, I think, because those 2 papers that I've just shown you are mainly focusing on specific drugs, and it would make totally sense to scale this beyond those specific approaches to also search for potential treatment-specific prognostic risk scores and not overall prognostic risk scores. You can also pretty good leverage routinely accessed data, which is in most cases very accessible for those kinds of researches. But in the end, it also depends on scaling the overall approach to generate a more broad and more representative database, which is, of course, a very good opportunity to work together with networks like EMSCO. We've also went out to develop our own our own approach to this specific topic, which led to the initialization of the research and development project KITE, along with Professor Platzbecker and his team at the Department of Hematology. We started out wanting to build knowledge-based therapy decision supports in multiple myeloma, in MDS, and also in AML. Due to the access to high grades and high detailed data, we were able to build a very great knowledge base for multiple myeloma, but we are very interested in scaling this approach into other hematological diseases as well. There's a lot of work done. There's a lot of work implemented, just waiting for clinical collaborations to actually build a great knowledge base based on data. How we approach this is basically by enabling so-called treatment outcome simulation by using a so-called similarity cohort. So you're basically entering patient data, and based on this real-world evidence database, some form of digital twin cohort is identified, and based on the observed outcomes of this twin cohort, there's an assessment about a range of possible endpoints that might very well classify treatment success. For example, remission, for example, time to next treatment or progressive-free survival, the occurrence of adverse events, and also quality of life if this data is available. There's also a lot of potential in this specific field for the assessment of new endpoints or for the investigation of new endpoints, which might be in some cases more aligned with the goals of value-based healthcare, so which to enable the derivation of new signals that more represent the patient perspective and not the actual biological or clinical perspective. And those are just some ideas for possible new endpoints, which might be interesting to investigate when the data is present. There's also been some work done on the aim of synthesizing clinical data, most recently in this paper, which I'm sure features a lot of EMSCO members in the author list. And the goal of this paper was to investigate whether it is possible to use deep learning algorithms to modify a significant patient cohort and change those features with the goal to obtain data privacy. So to be able to share this data more broadly for medical research, or in the end, maybe also for clinical trials, like for example, by simulating the control arm. And the results were very good in this paper. The approaches are very state of the art, basically, and I think it's very worthy to investigate the effects and the potential outcome that this technology might have in the future. One example that is very interesting for us as data-driven researchers is the ability to generate new data in underrepresented combinations of patient features. Like, for example, if you try to investigate the causal effects of a specific variable, but you have an 80-20 ratio in the occurrence of a specific mutation or a specific patient characteristic, then you might be able to leverage those technologies to scale up the counterpart, basically, and be able to derive better results in the end. There's also a very interesting topic that I've stumbled upon when researching papers for this presentation, which is the analysis of patient-created data. And there's a paper from last year, which basically used artificial intelligence and more specific natural language processing, so algorithms that try to understand written or spoken language, on social media platforms where patients are basically exchanging information about their treatment and about their experience. And what they did was to perform sentiment analysis that is then associated with a specific treatment. Like, for example, if you build a bot, for example, and you integrate this into a patient group on Facebook or on Twitter or X, then you can use this to find combinations between the mentioning of a specific target drug and the experiences or the sentiment of the experiences. Like, for example, azacitidine, not well received or very well received and stuff like that. And then you can build trends, or you can derive trends that come exactly from the patient estimation and not from a clinical assessment standpoint. And then you can obtain trends, and then you can use those signals for strategies more targeted on value-based healthcare to actually define or better define what value actually means in this case. So there's a lot of potential here. I think there's also a lot of potential focusing on non-English based forums or text bases that can then be used to derive those sentiments. And of course, there's also a great potential to define or to generate some actual real-world use cases on how this data can be leveraged to answer some specific research questions. Thank you so much for your attention and for the invitation.
Yes.
Yeah, very nice talk. Congratulations. I just have a theoretical question concerning KITE, for example. If you do your indices and then you find out that based on a particular patient X that will eventually probably not respond to a treatment line 6 months down the line, but then you have nothing to offer the patient. So what do you now do? Do you just say, okay, because I now know that he will not respond in 6 months, would your suggestion now be not to give the person any medication, or still to try something theoretically?
Yes. So the main goal of the project or the system was to build a second layer on top of clinical guidelines. So basically, for multiple myeloma, as most of you know, the clinical guideline basically states you can do this, and this without further recommendation, really. So there's a lot of potential for a range of specific combinations, at least in further therapy lines, but it's very hard to distinguish between those. And what we wanted to do is basically to extend the specific recommendation of this and this and this by there's a clear signal towards this potential path, at least in this treatment success factor. Like, for example, you can build estimations about that this will work clinically very well, but it's has a very high potential for risk events, and it might not benefit the patient from his individual quality of life perspective. And then you have like more signals that you can offer to the decision makers, which might be the physician, which might be the patient, or both in combination, so they can decide. Basically, we found a lot of evidence that this might help you in the long term, but it might cause some severe complications in the short term. Are you willing to accept this specific risk? And here is evidence based on 25 similar patients that have been observed in the past. So I think that there's also a thing to mention right here, that what we did is basically just designing and building and also evaluating the algorithm. But of course, it really depends on the data set that is beneath the specific application. Like if you combine all the experiences in Europe, for example, which might feature some at least comparable patient characteristics in some form, then of course you have a very broad knowledge base, and you will be able to find a significant amount of those digital twin cohort-based patients. There might be some rare conditions where signals are mostly unlikely to benefit any decision-making process, but for some cases it might actually work. So in this case, it's just another signal presented in the decision-making process, and this is our main goal with this.
Okay, so thank you very much. We are moving to the previous talk. So Elena Krisa will present the Harmony project, and we may have a discussion at the end with Andrea if necessary. Thank you.
Thank you. So good morning to everybody. So I'm going to present an update on the Harmony MDS project. And Valeria has been recently to Salamanca and gave me some of the slides, but there are no many updates on the first one. The second one, so the first one was on HMA in high-risk MDS and CMML. The second one is the only one we have already concluded, and the manuscript is in preparation. I will show you the data on discontinuation of lenalidomide in MDS del 5Q. And then we have other two projects, one on transplant, and one is a comparison between azacitidine in the control arm of the Verona trial compared to historical data on azacitidine in the database. And these two will depend on the completion of the first one. So the first one is the historical one. The aim was analyze data on patients with high-risk MDS and CMML treated with azacitidine or decitabine, alone or with other drugs, and followed or not by transplant. And there was a second step that was planned to compare this data with patients receiving intensive chemotherapy. These were the endpoints. I think you already seen this study before. But still, we don't have data completed and transferred in the Harmony language, so in the OMOP database. So even if we identified almost 1,200 patients treated with the HMA, only less than 1,000 have complete data transferred so far. So we don't have any new update on that. Then we have the project 3 and project 4. So project 3 I mentioned would be this comparison, and the project 4 would be a study on the, this, I think something went wrong with the slide, but anyway, would compare the outcome of patients treated with HMA again, and seeing the outcome according to transplant strategies as opposite at non-transplant strategy. But both of them will start after all the data will be on Harmony for the HMA treatment. Then I wanted to present, but I think something went wrong with the slide, doesn't matter, the data of the retrospective study on LEN discontinuation in patients responding to lenalidomide. It was a cooperative study. And the main goal was, again, to see the outcome when discontinuing the treatment while in hematological response and transfusion independent status. This was the patient population. The main exclusion criteria was discontinuing the drug for progression or lack of response. And we have presented data at EHA, and then we have also improved and increased the casuistic. Now the manuscript is in preparation and the study is closed. 118 patients, mostly women. These are the main characteristics. I want to show you just that there was a small group of patients that has started lenalidomide when they didn't meet the IWG criteria for transfusion dependence. So they had received lower burden of transfusion before starting. And all the patients achieved transfusion independence, 40% also a complete cytogenetic response at discontinuation. Reason for discontinuation was mainly toxicity, but there was also 40% of patients discontinuing for physician decision in the light of the complete response or patient decision. And this is the curve of transfusion independence duration. It is quite nice with a median of 60 months. And it was even better for patients who were in cytogenetic response at the moment of discontinuation or were treated for more than 12 cycles. And what's also interesting is that patients who started lenalidomide early also had a better outcome after discontinuation. This also in the light of data of the REV-CINTRA trial may be interesting. And when we rechallenged a few patients, 48 that lost a response, more than half achieved again transfusion independence, and at least 3 of them a complete cytogenetic response. This is underestimated because it was a retrospective study, so it wasn't planned to check cytogenetic response prospectively. And this is another pity that we couldn't really achieve or analyze any biological correlation with these responses because we couldn't have data. And this is the event-free survival, in which we consider loss of transfusion independence as an event, progression to high-risk MDS or AML, or death. And you can see that it was quite acceptable. And at multivariate analysis, the factors that impacted on EFS were the number of transfusion required at lenalidomide start, the IPSS revised, the number of cycles, and of course, age as expected. So this is the conclusion that probably in light of this study, we can safely discontinue the lenalidomide in patients who are treated for at least 12 months, and maybe in patients who receive early treatment with lenalidomide and achieve a cytogenetic response. These are all the acknowledgements, and I just want to conclude asking and sharing with you a study design, a phase 2 study exploring prospectively the discontinuation of lenalidomide. This was planned to be done before the retrospective one. We discussed it at EMSCO a few years ago, but then the lack of solid data prevent us to go on with the project. And now I think that maybe the interest in performing this study would be more the correlative studies, because then we can add information on the somatic mutation, on the cytogenetic response over treatment and after discontinuation. It would be, of course, a problem of numbers and to build a study, but I think we may still learn something more. And with that, I thank you for the attention.
Is there some comment and discussion with involving Andrea, if you want?
Very nice. I have 2 questions. For the first cohort with 5,000 patients with favacitidine, do you have data on the ferritin level of these patients?
No, I think the problem is that these data are collecting from registries and different databases from different nations, and still is the problem in collecting the clinical data on top of the molecular one.
I say that because, you know, we did a prospective study on Favasa plus iron chelations, but we have no control. I mean, to see, because we know this population with high ferritin level may have worse prognosis. So if we compare to the whole population, maybe we are comparing something which is not comparable. And
I think it could be maybe added on. So we could see when we complete the data collection if we can add this as a sub-product.
Yeah, because
it's a nice idea.
It's very interesting to see most of the hematologists who don't check for the iron metabolism. So as it's true, I mean, so I call for if somebody has a big database with the level of ferritin. And my second question is for the lenalidomide. When you have a response, is it always correlated with the extinction of the 5q- clones? And do you see if there is some correlation between what remain at the clonal hematopoiesis or non-clonal hematopoiesis, which may predict or not the response in long term? Do you check for this data?
Yeah, we checked, but unfortunately we had only 30 patients with somatic mutation data at diagnosis or over follow-up. So we couldn't see any signal of an impact of this mutation, even in the patients with TP53 mutation. They didn't have a different outcome, interestingly. But for some of them, we didn't have the VAF because it was done by Sanger, so difficult to say. And the cytogenetic response at the time of discontinuation impacted on the transfusion independence duration, but it not impacted on the EFS. The problem again is that we didn't have data prospectively during the phase of discontinuation. And also we did know that some patients were in cytogenetic response on lenalidomide, but we didn't know exactly at the time of discontinuation if the response was maintained. So for that, I think the prospective trial will add more information.
Just a point, do you imagine that you can do some immunohistochemistry of TP53 on the bone marrow or something? Yeah,
that would be also nice. Yeah, in the prospective phase. And also maybe immunologic studies on what the microenvironment is doing in this patient. Okay.
So this prospective trial, is it a planned trial or do you have funding already? Are you?
So as we're publishing, hopefully this paper, we will propose this trial for funding, and maybe in EMSCO we can also do this, because I think that we won't need a huge number of patients because it's more a proof of concept following the retrospective phase. We started from the design of a randomized trial. We ended with this. It could be enrolling 40 to 50 patients. It would be interventional because still is not registered unless you say that patients may decide to discontinue, but it wouldn't be ethically okay.
Mm.
And
yeah, I mean, again, this is a trial we always were dreaming of, but I think it's also the question, number one, who's funding it? Because now it's generic, lenalidomide.
But even before, they were not so interested in it.
I mean, now before they were not interested, of course, because you would stop their drug. So why would they fund this? And also the question is when does the trial start? Is the entry that patients actually can get Revlimid on a basis, on a routine basis, and then if they have 1 year, they enter the trial, or is this run in 1 year already part of the trial?
No, I think the trial will start at the stop, but we have to include like an inclusion criteria, patients that have been treated for more than 1 year and have a cytogenetic response check.
So like the CML stop
because
trials.
it would be less even expensive to start from the discontinuation. You don't need to provide the drug, even if it's generic. And we will try to apply with the national funding, probably for research that will spare money to the health system, because in the end, you may spare, okay, the drug is not so expensive anymore, but still is, patients coming to the clinic often and all the medical associated costs.
I mean, again, I don't want to.
No, it was here for discussion.
Yeah, prolong, but maybe, the question is, this is a very crystal clear trial, yes, but what's the gain of knowledge apart from the translational part, which of course is cool to have. So the question is whether it would make, we sometimes wonder whether these P53 mutation thing is really something triggered by Revlimid, like there's a blood paper on myeloma patients who actually received maintenance, and then there were more TMMNs with P53, suggestive that Revlimid may induce P53 mutation, or again, it's speculative, but here, it could be also interesting to randomize patients into Revlimid continuous versus stop, and then look at the mutational trajectories in patients starting with the same thing, which is a complete cytogenetic remission, TI, 1 year, and then you look what's the natural course, and rather power the trial on this than on what we already know, because the treatment-free phase and the this endpoint of TI loss, I think,
So you would be confident to use the retrospective data, for example, now to suspend. This is one point. And the second one is that, okay, no, this was
I mean, at least
as far as it will be
we
published
like
again,
10 years
yeah,
ago.
we
And also, I have tons of not tons, but I have like
yes,
five.
experience.
I had 5
experiences.
patients in my actually practice. The longest is 11 years.
Yeah.
Free of Revlimid.
And the second part of the question, because we thought that the control could be done in observational study, not to include those patients in the insurance costs of this trial. So if we manage to make it, because we can design an observational trial with the correlative studies, discontinuing a drug when it is out of the label. This is what we thought, because again, I think the main gain would be the biological one. And
Yes.
if we can perform this study, then we can use an observational study correlative in the patients that are normally treated with LEN as a comparison, maybe.
I mean, you presented we will not find the solution tonight, or at least it's not tonight. But
yeah,
it's noon. But I think you nicely showed what you are doing in Italy with this registry every 6 months, blood, genomic acquisition of genomic events, loss, complexity, blah blah blah, correlation with therapy. So maybe powering the trial, you think to do more on a molecular / MRD consideration would maybe lower the number of patients, because you, let's say, expect P50 evolution of P53 maybe being higher. I think this could be the hypothesis, that the genomic pressure of Revlimid continuation in a del5q patient with a small P53 clone is maybe higher, and so the increase of the clone is putatively higher compared to leaving the del5q alone without any Revlimid. So again, I'm just thinking loud. I'm not saying that I have the answer, but to bring
this could be the way of doing it.
But to bring this trial more onto a molecular translational level with endpoints and have a fair comparison, I think this would also incentivize people here in the room much more
to contribute,
because then it gets a really cool trial, where we understand a little bit more, whether Revlimid is a magic bullet or it's just not. I mean, there's this Terranci, I can't pronounce the name, but it's this Swedish English word, Terranci.
Okay.
Yeah. Okay. Good. Sorry for this, but this New England Journal 2010 paper. So where you have this CD34 sorting, and then you look for the del5q, which is still there. So this could be the starting point.
And answer the proper question.
And then look for, let's say, clonal evolution as a first-time primary endpoint in a clinical trial in MDS, starting with MRD, basically. Something like this. I mean, again, we can discuss, but
immune control.
But this would bring the trial to a next level, and also for funding opportunities, because then you know what I mean. So then it would be a biological study.
Yeah, sure. Okay, thank you. Any other questions? So we can move to the last talk of the session. Jean-Baptiste, Nicole, and Olivier, or Olivier? Olivier first, okay. Olivier Cosmiller. Is there a place to work on clonal hematopoiesis in Europe, I would say?
Yes.
Okay.
Thanks, Michaela. Thanks for the invitations. And hello to the last survivors of this meeting. Actually, this topic is at the end of the meeting, but you know that clonal hematopoiesis is big before all the topic we discussed about previously. I won't present personal data, but I will make a kind introduction to the real-life experience that Jean-Baptiste will present us. First, before this very important question, is there a place for clonal hematopoiesis or CH in the latest classification? And you know that the answer is yes. As in the WHO classification published last year, there is an introduction of the clonal hematopoiesis, focus on the CHIP, clonal hematopoiesis of indeterminate potentials, defined by presence of at least one somatic mutation with a threshold of death up to 2%. You also know that the other classifications, the ICC also presents clonal hematopoiesis as an entity. And to answer to this very important question, is there a place to work on clonal hematopoiesis? We have some questions: where could we find clonal hematopoiesis? Who is eligible for this research? Why could we work on clonal hematopoiesis? And when have we to test the patients? But also, obviously, in 10 minutes, we won't be able to answer to all these questions. The answer to this global question is yes. Where you know that we found clonal hematopoiesis as defined in blood samples, it's okay for everyone. Who is eligible for looking for clonal hematopoiesis? We'll see that we have a lot of patients, eventually MDS pre-leukemic stage and VEXAS patients, as previously described, essentially to describe the pattern of mutation and to understand how this mutation works into the inflammatory state of the patients. Why? Of course, to understand the mechanism of action of clonal hematopoiesis, and when maybe we have to establish some guidelines to observe and to predict the clonal evolution of patients presenting clonal hematopoiesis. You know that the true story of CH began since 10 years ago with 3 major papers, and one of them was looking for clonal hematopoiesis in patients with solid tumors without any hematological disorders. We know the papers, and we know that the sensitivity at the technique like WGS or WES at the time period was 5 to 10%. You know also that MDS, which was a long time considered as a pre-leukemic stage of AML, is also preceded by a pre-leukemic stage, which is now known as the clonal hematopoiesis of CHIP. And you know that during the MDS evolution, we have unbalanced proliferation and apoptosis, leading to accumulation of mutation and finally to the dramatic stage of AML that we try altogether to cure. Who is working on clonal hematopoiesis? I would say a lot of people. We have lots of results updated 2 days ago. But when we focus on CHIP and clonal hematopoiesis, we have less publication to look for. Briefly, you know that when we talk about clonal hematopoiesis, we think about mutations, point mutations, insertion and missense mutations. But you also know that now it's admitted that we have also chromosomal alterations, mainly observed by SNP array in patients without hematological disorders. So we have clonal hematopoiesis affecting gene and chromosomal region. You know also that clonal hematopoiesis affect genes which are present or found frequently mutated in myeloid and lymphoid disorders, focusing on myeloid for our topic today, and that the outcome of the overt leukemia of MDS or hematological disorders in a large scale are mostly latent in myeloid disorders and mostly more aggressive in lymphoid disorders. We will work on clonal hematopoiesis, large consortium, large lab, and from 200,000 individuals, which allow to define the main gene found mutated in clonal hematopoiesis, like TET2 and DNMT3A with age, from up to 600,000 patients. The next paper presented at the last ASH meeting, and they also found some correlation we all know now, meaning that there is some loci which are predisposition to acquisition of clonal hematopoiesis. Here you can read it, but you have the main modification observed according to the main mutation in the file, and they have confirmed in this largest cohort for the moment that there is a link between clonal hematopoiesis and telomere length and COVID intensity, which was new at the moment of the paper. Of course, as you know, with cardiovascular disorders and smoking, obesity, infection, and at least death at the end of the story. Sometimes clonal hematopoiesis could help. So we could find clonal hematopoiesis in patients, and there is this very useful paper described in patients going to stem cell transplantations, meaning that even if we found clonal hematopoiesis mutation and here, especially the NNT3A in donor from bone marrow, from CD40 positive cells, there is a positive impact on the survival in patients, mainly because clonal hematopoiesis mutations are associated with increased network of inflammatory activity which provide a fight against the rejection of the engraftment. Sometimes not. You know that recently again in osteoporosis is mainly associated with clonal hematopoiesis, and in the case where you have clonal hematopoiesis affecting the NNT3A, which has the same gene which was favorable for the engraftment on the previous slide, you have an other way of osteoporosis in patients with a very nice fundamental link between the mutation and the behavior of bone marrow cells. To know everything about clonal hematopoiesis, there is this review which explains, of course, the nature of mutation. We don't know why we have clonal hematopoiesis mutation, but what it impacts essentially inflammatory networks and involving hematopoietic cells. You know that clonal hematopoiesis and CHIPS are associated with hematological, of course, and non-hematological disorders, and the list is growing month after month. You know that in gut, we have an increased prevalence of clonal hematopoiesis, and that the TET2 mutation we found in patients with gut enhance the inflammatory pathway, which observed mainly involving the monocyte mutated in patients. And you know that every month we have new descriptions here showing that when the baby is overweight, we have a high rate of clonal hematopoiesis at adult age. There is no link, no explanation for the moment, it's just the constatations. And when you have also obesity, induced inflammation exacerbates clonal hematopoiesis, meaning that, okay, we have a clone with a somatic mutation, and that stress, oxidation, obesity can provide the expansion of the clonal hematopoiesis clone. We need a meta-analysis. This one, the most recent, shows that clonal hematopoiesis leads to a high rate of AML transformation, but not always. And we know here that the VAF of the mutation and the size of the clone is important to provide real clue to evaluate the risk of AML transformations. And so there is, to evaluate the risk of hematological disorders, the last published paper recently in New England Evidence by Hebert and colleagues show that there is a score, CHAS score, able to evaluate the evolution of patients. And to make briefly, they have more than 152 patients without CQs, and only a large amount, 10,000 patients with CQs or CHIP, and they could discriminate the evolution of patients between the three groups according to simple parameters, sometimes on cytology parameters. So, okay, but what is about the real life? What can we do in France or in Gustave for taking account of clonal hematopoiesis? It's time for Jean-Baptiste.
Okay, thanks a lot for this nice overview. Then, as I'm working in a cancer center, we'll more focus on therapy-related CHIP and the risk of transformation to therapy myeloid neoplasm. As you may know, the incidence of CHIP in cancer patients is very high, around 25% of the cancer patients. And it's in a part due to the clonal expansion to mutation in DNA damage response gene like TP53 or PPM1D gene with cytotoxic treatment. And unfortunately, as it has been shown for healthy patients, patients with CHIP and cancer have a shorter survival, and some of them have more hematological cancer. Okay, but all those papers are retrospective. And CHIP, is it a reality now or not? Well, 3 years ago, we set up a specific consultation for solid tumor cancer patient in Gustave Roussy with cytopenia. And sometimes, because we are not able to do the differences between toxicity and MDS, we are doing a large hematological workup. And for example, we recently published a paper on PARP inhibitors in breast and gynecological cancer patients who had some hematological toxicities. And among the 37 patients, 1/3 of them had therapy myeloid neoplasm. But more interestingly for the topic, 1/3 of the others have CHIP or CECAS, and most of them have TP53 or PPM1D mutations. Moreover, our colleagues from solid tumor are now using circulating tumor DNA for sequencing for treating advanced cancer patients. It's what they call liquid biopsy. It's just sequencing in the blood, but in the serum of the patient. And at Gustave Roussy, each year, they are doing around 2,000 patients. They are sequencing those patients with a very large panel, 324 cancer-related genes. And inside those genes, there is a few, but there is some very important recurrent M gene. I will say just SRSF2, RANKS1, and PPM1D are lacking in this panel for very important M gene. And as you can see here, we found in those patients a very high percentage of CHIP, around 20%. Then, based on this data, we gave some recommendation for hematological advice, and patients with cancer-related overall survival of at least 1 year, and with VIF more than 10%, except for JAK2 or MPL or MYD88, which is respectively to the VAF, can have a hematological consultation. You can see here the issue we have with TP53, because TP53 gene is the most gene mutating in cancer, then it's impossible to do the differences between the origin of these mutations. It's why we don't include those patients in our recommendations. And then we published recently a paper in around 1,500 patients who receive who perform a liquid biopsy, and we recommend hematological consultation for 45 patients. And at the end, we made the diagnosis of 6 occult malignancy in those patients, 2 MDS, 2 essential thrombocytopenia, and 2 lymphoid disease. Then we think that maybe we were able to set up a specific CHIP molecular tumor board at the Institute to talk about those patients. Then we began last year to do that and to discuss all the CHIP we discover in the cancer center. The MTB, in the MTB, there is some hematologist, oncologist, and some molecular geneticist from oncology and from hematology, and some bioinformatician. And we discussed the case with all the patient characteristics, the complete blood counts of the patient, the cancer prognostics, and the characteristics of the gene mutations. And we try, when we can, to assess the CR score. And at the end, we try also to do some recommendation. So I will give you what we did for the last year. It's each month. We discuss around 30 cases by month, and most of them, 60%, are from liquid biopsy results, and around 40% from the NGS panel we are using in hematology. And just 4 patients were discovered by germline testing, but they are very interesting because they have TP53 mutation, which is very high risk mutation, as you know. Then when you have a look to the results of the 2 cohorts, the liquid biopsy cohort and the M cohort, you will see it's not exactly the same patients. In the liquid biopsy cohort, the patients are on treatment. It's more male, and it's more lung, colorectal, and prostate cancer. In the M cohorts, most of them have an history of cancer, but just a few of them have no history of cancer because it's M consultation. And when they have a cancer, the time between the MTB and the cancer is 30.5 years. Then some of them are in remission of their cancer, and it's more lymphoid disorders, breast cancer, and gynecological cancer. Then let's have a look to the mutation. Here you can see that in the liquid biopsy, we found the usual mutation, the MT388-2XXL1. And because we address the patient irrespectively to the VAF, JAK2 mutated patients are relatively high. And except for JAK2 and MYD88, the VAF of the other mutation is very high, around 20%, just because it's based on our recommendation to address patients with more than 10% of mutation. And even for JAK2, you can see that you have some patients that with very, very high VAF. For the M cohort, you can see that the main difference is the huge percentage of PPM1D and TP53 mutated chip, around 20% for each. And because there is no selection, the median VAF is lower. But you can see here that there is a lot of patients with a very high VAF in this cohort. Then after the MTB, we discuss the cases and we try to classify them. As you can see in the liquid biopsy cohort, it's more cheap patients. And there is, I will say, only 4% with high CR score. But 4%, you have to think about that the paper that Olivier showed before, it's 1% in the cohort which has been described by the team of Ebert, but 1%, but it's a few percentage of all the cohorts. For the M cohort, you can see it's more sickest patients, 40%. It's normal. It's patient addressed in MN consultation for cytopenia. And here, the CR score is very high. CR score, it represents 16% of the patient, which is very, very high. Then at the end, we try to do some recommendation. For the liquid biopsy cohort, you can see 10% of the patients were addressed in hematological consultation. And for the moment, we made 5 diagnoses in 1 year, 2 essential thrombocytopenia, 2 MDS, 1 CML. And despite the fact that the follow-up is very short, just a few months for the M cohort, you can see we have already 3 patients who progressed to hematological malignancy, 2 MDS, 1 CML. And after, we try to recommend not to follow the patient with very low risk NGS patients. Okay, but after what you try to do, it's to have some clinical trial. Then we set up a translational clinical trial called clonal interception, which is a prospective monitoring of clonal hematopoiesis in cancer survival. The trial will begin soon. It will be a prospective monitoring of chip progression to therapy myeloid neoplasm in very, very high-risk patients. And we will take some blood every 6 months to this patient and try to describe the mutational evolutionary history of the mutation with panel sequencing, SNPRS, single cell sequencing, but also, as it has been discussed before, We will try to do machine learning for cytomorphology, spectral cytometry, and also cytokine dosage. And hopefully we will find some biomarkers. Then I told you the first inclusion of the protocol will begin in less than 2 months. And we have already, with the MTB, 40 patients eligible for this program, but we will open it to have more patients to include. Then I wanted to thank all the people working in this topic at Gustave Roussy, especially the CHIC team, and especially Aline Renville and Elsa Bernard. And I hope I convince you that there is a place to work on clonal hematopoiesis. Here, it's a little focus on therapy clonal hematopoiesis, but for sure, there's a lot of things to do. We can do screening. For example, it's not cheap to do NGS than in some country or in some center. You can't do NGS for cytopenia, but I think it's interesting to do. We can do prospective database. We can do some recommendation, research protocol, because a lot of protocols are retrospective, but prospective protocols are very important to find very good biomarkers. And for sure, in the next years, and already there is some trial to intervene and to prevent the apparition of a therapy myeloneoplasm. Thanks a lot for the.
So question, Olivier.
Very nice work. I have 2 questions. The first one is when you show the ctDNA versus classical clonal hematopoiesis. I think it's very interesting because now we do see, for example, in inflammatory disease, when you look at the inflammatory sites, you may find some mutation of clonal hematopoiesis, whereas in the peripheral blood, you do not see anything. So do you think that it is more sensitive to look at ctDNA? Because it may be complicated because you know what would come from the tumor or what will come from the microenvironment, because we may expect that clonal hematopoiesis in this case may impact the prognosis of the tumor.
What is difficult here, it's not a comparison to ctDNA and MNGS, then it's just the result of the kind of patients who are coming. But when we do the both, in fact, there is no huge difference when the VAF is very high. Then we are finding exactly the same mutation with the same VAF. But the problem is with ctDNA, we found a lot of mild clonal hematopoiesis and really don't know what they are. A lot of DNT3A, a lot of TP53, and we don't know if it's cancer specific, if it's M specific, what it is. And I think, yeah, you're right. It's very sensitive, and we are not able with the standard NGS to have this sensitivity, and I don't really know what it is. But it's a good
question. It should be interesting too, because we see, for example, in some lymphoma, you see in myeloid cells in the tumor, clonal hematopoiesis, or in the blood by NGS, you don't see anything. And my second question, in your prospective protocol, you look at MDS or AML or so on, but did you look at the impact on the outcome of the cancer? Because I think it may have a strong impact on because the myeloid suppressive environment of clonal hematopoiesis, for example.
Then it's a good question. It's not the question of our protocol, because I think we'll see, but I'm not sure we will have a lot of patients to do that. But we have a protocol in Gustave Roussy because it's a global program called interception program, and for cancer patient, especially for lung cancer patient, they are doing that, and they are looking to the incidence of cancer in healthy patient, and there is ancillary studies, and they are looking to the clonal hematopoiesis, and I think you're right. There is an increase. It has been published for lung cancer, but there is an increase of cancer with some chips.
Thank you. So I think. One question?
For the presentation, did you have chance to analyze some sample before cancer in your cohort?
Yeah, at ASH this year we have an abstract on PPM1D mutation, and we have some sequential blood samples for ovarian cancer women. At the diagnosis of the cancer and during the treatment. And when we have a look to the mutation, it's weird because In fact, the mutations are here at the beginning before the treatment, but in a very, very low level. And then when they receive the treatment, and especially because it's alkylating agents, cisplatin, you see an increase with the chemo of the VAF. Then yes, we have this kind of thing, and we are doing that for PARP inhibitor patients, and we have a program on that here.
So actually, there are many questions. Can I have two?
You can, but
Yeah.
if you
Yeah.
want to have time to discuss
Yes, maybe they,
overall,
yeah.
okay.
Okay, good.
Go on.
Thanks a lot.
Okay, so thank you very much. Katharina Goetz is not able to attend. And finally, I understand that Uwe proposed to go for a discussion about unmet needs, future clinical trials, and future fundamental research. So this is the title of the previous session, of this session. And are you still agree?
No. I mean, I can
agree?
do whatever you want, but you know. Yes, I think we can postpone the discussion
Completely
to the lunch, if that's okay.
Okay.
And again, I think I presented the Luz Plus.
The Luz Plus
already
yesterday.
yesterday. So
Yeah.
it's high dose luspatercept. And if anybody's interested to know, please approach me at the lunch.
Okay.
And actually, I think we can postpone the discussion to the lunch meeting.
Okay, so we may have a discussion about what we presented as an option, as a therapeutical option during this session, during the lunch. So the point is the lunch is upstairs, the 7th floor, so on the rooftop. So it will be very nice because it is sunny. Okay.
Okay, thank you. You want to say that the next EMSCO meeting will be in Berlin? No, it's okay.